accountability and a path forward. Appreciate the participation of all the witnesses today, and we look forward to a candid and constructive conversation. I will also just say for the record, this hearing was originally scheduled when we were supposed to have the budget. And so we had to make some scheduling. We had to beg for a room, to be very honest. I had to make some changes on that. So for the public who may be watching, it wasn't our intention to quote unquote block anybody out, but we did have to make some strategic decisions in terms of us having a conversation today. All right, with that, we'll move to our first panel. I don't see our first witness here, Jaren Hill-Lockridge, who is from the advisory board and the chair of the Ward 8 Health Council. But we do have Dr. Marilyn McPherson-Corder, who is former chief of staff at UMC, who is on Zoom. So we'll start with Dr. Corder. Dr. Corder?
Hello, good morning, I'm here. Can you hear me?
Yes, ma'am. When you're ready.
Okay, so yes, I am a Ward 7. I grew up in Ward 7 and 8, and well, Ward 7, went to school in Ward 8 for all of 12 years. So I'm a Washingtonian 3 generations. I became a pediatrician right here in DC at Howard University, did my residency in pediatrics, and then did 2 fellowships, one in genetics and one was in adolescent medicine. I've been in private practice for all of 40 years. And I had the honor of being the chair of the nursery at what was called at that time Greater Southeast since 2000, and then became chief of service for 4 years, and that was in 2015 through 2018. I am a community doctor. I know many of the community doctors who are still in private practice, who were in private practice adjacent to the hospital, the medical professional office building for the physicians for 30, 40 years, and practices in the area. And they practice medicine in the area generations. So when we heard of the new hospital, we were excited. I mean, I was in board meetings with leaders in the district, and we know our hospital was old, and I wish that it had stayed open. I said, it's enough. We have enough need that we could have 2 hospitals in Southeast, but of course that wasn't my decision to be made. So as we continue to hear of the hospital opening, we unfortunately were beginning to see less and less funding for our hospital. And there was a time when I had to come in front of the council to pretty much beg for the $7 million that they had cut from 20 to 27 million. But we ended up getting that, which allowed us to function and to continue to operate in within the financial strains that we had and we were put in. Our hospital was not perfect. Well, no hospital is, but we had complaints from the community of be it wait time or just didn't like the service. As a physician on staff, we always wanted to do our best. And as far as I saw, we were trying to do our best with the limitations that we had. My mother and my aunt was there. I mean, I trusted the hospital that much. I could have had them anywhere. I'm on staff at 4 other hospitals, but I was comfortable with them having a service there, being treated there. An emergency room I felt was pretty good. Sometimes we would have to send patients elsewhere depending upon what specialties we had, but as much as we could do. After a while, GW took over the emergency room, and we ended up also having the labor and delivery closed for an incident. And I say an incident that was not even our patient, but I won't go into there. So that meant that the mothers in Ward 7 and 8 did not have a place to deliver babies. And I don't know how much time I had, but to deliver babies. And unfortunately, had to go elsewhere to one of the hospitals in Northwest. There are 5 hospitals in Northwest. There were none in Southeast, none in Southwest, and Providence was closing as well. So that was very distressing news. And unfortunately, we had poor outcomes from babies being born in the ER at United Medical Center or in an ambulance trying to get across the bridge. Where are we today? Well, the hospital itself closed, and then the doctors, from my understanding, we were told that we could join Cedar Hill, and then last minute we were not invited to join Cedar Hill, and we had to go elsewhere because many of our practices was attached to the professional office building, and that's difficult, but it happened. Some doctors just left DC and went to Maryland, so the patients did the same. What I'm hearing now as a community doctor still involved in the community are not so good news. We're hearing that the services that was promised at the opening a year ago are not there. The care, the culture is not positive, and it's very concerning. I've been in conversation. I want to continue conversations with the leaders because my heart is for those in Ward 7 and 8. I'm in private practice in Northwest, but I can also still come back to private practice where I grew up. So that concludes. If you have any questions, please don't hesitate. But I'm fully committed to continue to serve the residents for Ward 7 and 8. And we're willing to partner with those leaders at Cedar Hill.
Thank you, Dr. Corder. I do have some questions, but I guess my colleagues aren't here. I still want to keep myself accountable of time. So if you could put me on a 7-minute clock, Ashley, thank you. Okay. Dr. Corder, one of the things that we have heard feedback around was the experience of community physicians trying to apply for privileges at Cedar Hill. Can you talk a little bit about that experience? I've heard either someone was denied, or I actually have heard more that they just simply haven't heard back. But I wanted to hear from you.
Well, I know personally, at least 5 or 6 doctors have not heard back. One in particular applied last year, almost to this date, and he hadn't heard back, and he is a well-trained surgeon. I know recently, over the last 3 to 4 months, some doctors have applied, and I don't want to give their names because it's HIPAA violation, but I gladly can let you know and get those names, and you can reach them. They had applied, hadn't heard, and then they were told recently that they now have to go through another process because there was changing of the guard in terms of their applying. There have been doctors who are interested in becoming part of the ambulatory, the clinics, specialty clinics, and was quoted an enormous fee for renting up to $8,000. Now, I don't have that in front of me, but that was what I was told. And my feeling and the community doctor's feeling is, well, maybe because we were dispersed and, basically said you can't come, maybe there needs to be some consideration, not a maybe, there should be some consideration to allowing either no rent for 6 months or, some discount, because we have to re-establish our patients to come there and to get everything back where we were as if we were at Greater Southeast United Medical Center. So yes, we have had folks get either no information or denied, and mainly more no information. And it's like they keep saying apply. But then there are other doctors who are like, well, if we apply, what does that mean? Who do we work for? And where's the leadership? And where the peer review? So some people have said, I'd rather not apply right now until things are straightened out, until things are clear, until the outcomes and what we're hearing, what's going on from the ER to the inpatient to the surgery has a better, have a better reputation.
Okay, just for comparison, what was the rent at UMC in the professional building next door?
Well, some of it was actually free, and the other ones was $2,000 or $3,000 versus $8,000. So it's drastically higher. And I know it's new. I understand, and development costs brand new development, but exorbitant is majorly higher. It's like to the point of very restrictive.
Okay. In terms of, I mean, I had a list of questions around like some of the barriers that community physicians are having, but it seems like the biggest barrier is that no one has called them back.
Yes.
Okay. So that's not even a, oh, you didn't meet the requirements. Oh, we don't have space. It's literally somebody just has not made it through the process of calling folks back.
And they've been calling and they've just been getting a runaround. And, things are sitting on desks. I'm not sure why. We're not GW. We're not part of the MFA, but we're community doctors who are interested. And we did meet with Ms. Daniels, and it was a positive meeting. I felt it was a positive meeting. And we met with the board before Mr. Coleman left, and we had at least 20 doctors from the community there saying, look, we really want our patients to go there. They're going elsewhere. They're going to Northwest, et cetera. But we're talking about bringing hundreds and hundreds of patients back. That's convenient in their neighborhood to get served, but they're not going to come. Let me just make sure you're clear. They're not going to come come to a place that has right now not a good reputation. They're hearing, and they're not going to come to a place where their doctors have not been invited. And it's not community doctor friendly.
Understood. Well, thank you so much, Dr. Corder. We've been joined by Councilmember Zachary Parker from Ward 5, who's a member of this committee, and online, Councilmember Trayon White from Ward 8. Jaron Hill Lockridge has also joined us virtually, but Dr. Corder's clearly in her office. And so I want to see whether or not Councilmember White or Councilmember Parker have any questions for her so that she can get back to the business of serving her patients. Councilmember Parker.
Thank you. And I jumped in halfway through the question, so I may have missed this. But Dr. McPherson Corder, what would you identify as the barrier to bringing more of the community physicians on board?
There needs to be an in-house medical exec team of doctors who will be community doctor friendly and will be able to get back to the doctors who are applying. Everything now goes to GW, and then from what I hear and see, the response is not there. The follow through is not there. And, they'll say, put your application in, and sometimes even the link. So in the best situations would be an HR, everything decision making would be right there at the hospital on that site. And as well, we need to have a physician run administrative group that is community, made up mainly of community doctors, that will make sure that those things that were needed at the hospital is addressed. If you're across the town, or if you're not there, or if you're not used to that community, there are going to be things that you just totally don't think about, totally unaware, and it's just not going to, the outcome is not going to be good. So it needs to be community physician friendly, as well as understanding what the community physicians can bring and want to bring back to Cedar Hill, or to Cedar Hill as we know it's not there.
Understood. It is my understanding there has been some turnover in terms of leadership, both in the emergency department as well as elsewhere at the hospital. In what ways do you think that's contributing to the culture that you say is not quite as positive as it should be?
I know 10, 20 people, at least 15 people who work there or have worked there and have said, I can't stay. My license is on the line. From nurses to physicians to administrative folks, they're like, it's.
Can I play devil's advocate? And I totally hear what you're saying, and I believe it to be true. I recently had a conversation with someone from Cedar Hill, and they would say, it's almost like we're being picked on. Everything is being amplified for us and being reported out in the media, where hospitals across the district are dealing with some of the same symptoms. How might you respond to that?
I'm on hospitals, and I understand no place is ideal. And I will say this, as I'm on other hospitals and have been on other hospitals, we got a bad rap at United Medical Center. Everything that was anything negative was highlighted. But what I'm hearing and what I'm seeing, I have relatives who have gone there. Patients are calling me. And we are now hearing other hospitals complaining about patients coming to them after they've been mistreated or not completely treated there. I've never seen such. And I've been in practice. I've been in Washington all my life. I've never seen such. So when you ask me the comparison, I think it's majorly increased, more so tenfold. Let me just say tenfold, because it's only been open a year. And a brand new hospital needs to have that should be the flagship. It's like, okay, this is the new hospital that has all the equipment. I'm excited as a pediatrician to come and help in the nursery. As I was chair of the nursery, we had to beg for equipment when we were at United Medical Center. I'm hearing.
I only have a minute left. I hate to jump in and cut you off, but Chairperson Henderson is a stickler for time. So if I had to ask, what might you say is the low-hanging fruit opportunity for the district or this committee? Where would you point us to focus on?
To listen and partner, the community doctors, we need to partner with the district or UHS or whomever, that they really hear us. We could talk, but really at the table and making some changes and putting our group in some leadership positions, and then walking through and listening, not just listening and not acting, but listening with the intent to change.
Understood. And last question, follow up. You may have given this. How many doctors would you say have applied that you're aware of that have not heard back?
I know, I'll be conservative, at least 12.
Wow.
And now let me say for the record, I have not applied. And I'm going to tell you why. I saw what was happening. And then before I put an application in, and there's several of us that are like that, where is it going to go? Why is it going to sit for long? Who can I call? So some folks, and then some people are saying they don't want to apply because they don't feel comfortable with practicing there when the different ancillary, the nurses or the different departments are not favorable to the community.
I'm going to stop there, and I'm going to thank you for your engagement, and I appreciate you taking a break from serving to testify today. So thank you.
Thank you.
Thank you. Councilmember White, do you have any questions for Dr. Quarter?
Yes, I have one. I want to thank you, Dr. Quarters, for your years of leadership and service to the community and your continued advocacy, not just for you, but for other doctors that has been serving residents east of Anacostia River for decades. I guess during my correspondence with Dr. Daniels, she explained that some people were making progress in their application process. Do you see that at all? Can you speak to what progress has been made to those who have applied?
Well, and what I like to do, and thank you, Councilmember White, that's what we keep hearing. And then when we talk back to the doctors, they're like, well, we did. And they call back and they said, now we have to start all over again sometime in April. So it is not a favorable turnaround or response. And I'm not, and like I said, I didn't apply. I have not applied for these reasons. So I think that whomever is saying that, they need to look at the applications, and we can send the doctors to them and then say, okay, where are we now with this? Is it temporary? Is it apply somewhere else? You have to start all over.
Why are they starting all over? What's that about?
Well, that was what I was told by one of the doctors. He said his application was in the pipe. And they said, well, it's a new group of folks taking over the doctors. And I think it's now UHS. I don't know. They didn't talk to me, but I know that it's not completed yet.
And one of the things I saw in a meeting we were in with the board was that one of the doctors said he was there, but he didn't get any patients. Can you speak to, do you know why that is? And I know it's not your question per se, but just from your perspective, if you can give some light to that.
Well, there's a doctor who's there, and the understanding was he didn't get any patients. They were being sent to GW, but they wanted him to bring his patients to Cedar Hill to generate business, obviously, to generate funding, et cetera. But that particular doctor was under the impression that as he was on staff, that he would be the receiving doctor of those cases that he did not get, that was not referred to him. So, I don't know what the status is now, but I think that what needs to happen, we need to have a real sit down, a real positive, transparent conversation, that when we do come on board as we want to, that is not for naught, that we have active leadership role, and begin to get these patients. Every day it's a delay, and that's a delay, and that affects health and lives. And, it's not about, what's the next move, et cetera. It's more of, let's just get this job done. Let's get it done. Let's open and open the conversations, and let's work together, because I hope I'm right that we all have the same mission, which is to care for Ward 7 and 8 residents. And that's what we've all been about. This is not a power, hey, I'm not trying to make anybody feel bad. I'm really not. I'm from Southeast, from Parkland. I want the residents of Ward 7 and 8 to enjoy the health that we have here in Northwest. My office is in Northwest, and it's a different, it's just different, the care that they receive in the hospitals here versus Cedar Hill.
Thank you. Last to the chairwoman, just note that I see they have been talking about, Cedar Hill has been talking about doing a job fair. I know they have a few thousand applications, and I just know some people there's been a high turnover in staff. Unsure, I'll be in and out of this hearing. Just want to make sure we follow up on them as far as staffing it up at some point during this hearing. That's all I have for you, Dr. Porter. Just appreciate you coming today and speaking. I know we have Cedar Hill Lockridge here, who's also been in the meetings. Thank you.
Thank you.
Thank you. Ms. Lockridge.
Well, good morning.
Sorry, Dr. Porter, thank you so much.
Okay, thank you.
My turn now?
Yeah, go ahead, Jaren.
Okay. Good morning, council members. My name is Cedar Hill Lockridge, and I serve as the chair of the Ward 8 Health Council, and I also serve as a board member to Cedar Hill. And I come to you as a mother, a neighbor, with somebody deeply rooted in the health and well-being of the great Ward 8. First, I want to acknowledge that Cedar Hill Regional Medical Center represents a piece of our comprehensive healthcare ecosystem. For generations, east of the river residents have experienced gaps in our access to high-quality healthcare, timely and culturally responsive needs. And we recognize that with the opening of this hospital, that it's not just about infrastructure, but it's about trust and dignity, and we're trying to really get this right. And I want to be really clear about what I'm asking for. As a mother, the well-being of our young people is really key. I think that there's a real opportunity here, and not just an opportunity, but a responsibility to be more intentional about what we're doing as it relates to our young people. We have Children's National that's been here in the community for quite a while, whether they were at UMC, whether they're at the ARC, or whether they're at the Big Chair. And they've for a long time been a trusted provider when it comes to making sure that our young folks are taken care of, not just across the district, but especially here in Ward 8. So one of the things that I want to be clear in asking for is some really clear understanding as to what does our healthcare ecosystem for our young people look like? What does the partnership between Children's and Cedar Hill, what are we doing there to make sure that it goes beyond just a name and affiliation, that it's true integration, that they have shared communication and pathways, coordinated referrals, and that the specialists that are at Children's are a part of the ecosystem over at Cedar Hill as well. I've recently had conversation with a couple of different stakeholders within, again, our young people, specifically healthcare ecosystem. And while everybody's really involved with the adults, and I'm not saying that we don't, that's not important, but as a mama, I want to make sure that we have some family-centered, culturally responsive care that's integrated into the community that we currently have. That the accountability and feedback loops are really clear. making sure that this is more than just a single moment. This has been open for about a year now, and that this is bigger than just Cedar Hill. But again, how does this relate across the entire Ward 8 healthcare ecosystem when it comes to our young people? At the Ward 8 Health Council, we're committed to working alongside, whether it be Cedar Hill, Children's National, or any of our community partners and doctors in the district that make sure that the promises that have been, given to the great Ward 8 are finally coming to fruition. Thank you again for the opportunity to testify. My kids are on spring break right now, so if you hear them in the background, I apologize in advance, but I'm here for any questions you may have.
Thank you, Ms. Lockridge. Been there. Everybody's seen my little interns on the screen. We're going to do 5-minute rounds with Ms. Lockridge so that we can keep things moving. Okay, so Ms. Lockridge, I do have some questions for you, not just in sort of your capacity as the chair of the Ward 8 Health Council, but also as a member of the board. And you and I talked about this, right? In some ways, many of us are living with a hospital operations agreement for which we weren't there at the beginning for its signature or discussion or debate about it. In fact, when I was thinking and preparing for this hearing, the only two people who were here at the beginning when it was signed on any side of all of the stakeholders is the mayor and Wayne Turnage. Everybody else has changed. Deputy Mayor for Planning and Economic Development, changed. Head of UHS, changed. Head of GW, changed. Head of GW Medical Faculty Associates, changed. Head of Children's National, changed, right? So I want to acknowledge we are all dealing with a document that we did not write. That being said, I had to go back to the document. It exists, it's online. We put it on for folks. Now, Article 5 of the Hospital Operations Agreement is on governance. And its first line says, the hospital shall be governed by a governing board, a majority of whose members shall be appointees of the operating entity, including without limitation officers and employees of UHS, DHP, or the operating entity. At what point did the Cedar Hill board become advisory in nature? Because the operations agreement says governing, not advisory, which is a confusing piece to me that I haven't been able to get an answer to.
It's not my understanding that we are an advisory board. It's my understanding that we are a governing board.
Okay. How do you know how many seats are currently filled? How many are vacant of the board? I've been asking. See, when every other hospital, I can go to their hospital website and I can pull up who their board is. I can tell you who's on the board at Children's. I can tell you who's on the board at MedStar. I don't know who is on the board at Cedar Hill. How many seats are on the board?
It's my understanding that there are 13 seats on the board.
Okay. Are there 13 members currently?
There are 11 members currently, is my understanding.
11 members currently. Okay. How often does the board meet?
Quarterly.
Okay. When was the last meeting?
Give me 1 second, I'll pull up my notes.
Okay. So in your understanding of it being a governing board, what was the onboarding for the board like? Was there an explanation in terms of here are your roles and responsibilities, here's how often we're going to meet?
We have a retreat coming up soon. So
I'm sorry?
We're having a board retreat coming up soon. So a lot of those details will be fleshed out in our board retreat coming up.
So a year in, the board is now having its retreat.
Correct.
Okay. Okay. When the board raises concerns or makes recommendations, how are those handled by hospital leadership? Or has that not occurred yet?
It has definitely occurred. But I also want to be clear that we have a board chair that I feel like might be more appropriate for a lot of these questions. So I want to, make sure that I'm not stepping on any toes as it relates to our official board roles.
Okay. That's fair. I think we did invite the chair to join us, and he declined. Offered a phone call instead, but it's a public hearing, so we got to have some of these questions on. So I appreciate you sort of putting in on that. In terms of your Ward 8 Health Council hat, you know, we've certainly heard of some experiences of folks being unsatisfied. What do you think is one of the biggest barriers currently facing the hospital from a perspective of connecting with the community?
I would say that there has been, as you mentioned at the beginning of the hearing, significant leadership turnover. So that the people who made the promises a year ago, 2 years ago, 3 years ago, 4 years ago are no longer in those roles. So they're not, the promises aren't holding true to what the community, you know, what was told to us and sold to us.
Okay. So the hospital operation agreement requires UHS to establish a patient and family advisory council that includes community representatives from Ward 7 and 8. To your knowledge, has that council been established?
Not yet, but it's my understanding that it is in the process of happening per a recent conversation with Ms. Daniels. I know that there was the community advisory council prior to, you know, where we are now that was sunsetted, and there was supposed to be a patient advisory council, but it's my understanding that has not happened yet.
Okay, but it's your understanding that the community advisory council has been sunset?
Correct.
Okay. The letter from UHS response to me, they said that that community advisory council meets quarterly. But I'm over my time. Councilmember Parker?
I'm going to generally pick up on the theme, and I don't know if I've met you, Ms. Lockridge, so it's nice to meet you. In terms of your governing role on the board of the hospital, what do you see as the board's responsibility?
So I think that there are a couple of different roles within the makeup of the board. There are UHS representatives, there are community representatives, there are government representatives, as well as GW representatives. I think that together we're all responsible for overseeing and making sure that the hospital runs to the best of its ability with the resources and support that we currently have.
And what does that look like in terms of accountability? So there are negative reviews, metrics aren't being met. You alluded to high turnover. What is the board's role there, and how is that being discussed in terms of what action steps you're going to take?
So we're currently, as I mentioned earlier, we're in the process of fleshing all of those details out. Unfortunately, when we were onboarded, it was not clear as to who was sitting in what role and why. We have recently undergone elections to have officers within the board, and I want to, I am a board member. However, I'm not an officer within the board. I am a community representative trying to do the best that I can on behalf of Ward 8 residents.
Understood.
So I wanted, go ahead. No,
Sorry about that. I think there's a lag, so I don't mean to talk over you. How many community members hold elected office on the board?
So our board chair and our vice chair are both community members.
Okay. And again, I just want to come back to the accountability piece. So when there's leadership turnover at the hospital, how is that discussed or brought to your attention as a board member?
Within the C-suite, I'm assuming you mean, of the hospital.
Sure, yes.
It is brought to us within our quarterly board meetings.
And I'm assuming it's shared as an FY, or are you being asked for input, engagement in any way?
No, it's being shared as an FYI. We are not being asked for input about how they are handling their roles and responsibilities.
We heard testimony earlier today, and I'm sure this is going to come up, that there's a struggle in getting these community physicians into the hospital. What have you as a board had about that?
So we had a meeting. We had a meeting with the community doctors. They actually were a part of our most recent board meeting. Yeah, the community doctors were a part of our most recent board meeting when the previous CEO also, announced that he was in his role. So we met with them as well and heard from them as well.
Okay. Are minutes kept of your meetings?
Yes, they are.
And are you able to share notes of the committee's key actions over the past year?
I believe our chair and the board secretary can share that with you. And I believe one of our board members is going to testify later on today in this hearing.
Okay. I will be sure to ask them. And on the record, I'm asking if you can assist as a board member. The committee would like either the minutes, but generally, what principal action steps has the board taken over the past year that is contributing to the success of the institution?
So I will definitely support and provide, whatever support I can with getting those minutes to you guys. And I'll say there have been a number of conversations that we've had as a board, whether it be within the board meeting, some of our on the side conversations, and I also say in my capacity as the chair of the Ward 8 Health Council, I have done several things to try to connect the dots as our healthcare ecosystem, recognizing that Cedar Hill represents about 20% of the whole ecosystem and the other 80% also needs additional support. Mm-hmm. So whether that's the FQHCs, the community-based organizations, or our MCOs, really trying to strengthen the pathways and the referrals while using as a lightning rod of investment within our ecosystem, but understanding that it's not the silver bullet that some people are trying to make it out to be.
I hear you loud and clear. Well, thank you for your testimony. If you want to also follow up with recommendations for how the committee can support that ecosystem, I would be open to receiving with you on that as well.
Absolutely. I appreciate it.
Thank you. Thank you.
Thank you, Ms. Lockridge. And I just want to say, when the mayor's office was sort of pitching this project in terms of the hospital and the agreement with UHS, I wasn't on the council. I think I might have been a staff, maybe not. Nonetheless, I was a resident. I was a citizen. And one of the things was that the district wanted to get out of the business of running the day-to-day to a hospital. And so this has been sort of the challenge, is because our oversight is a little bit under United Medical Center. United Medical Center, they testified every year. I saw their budget. I saw them during performance. We had their meeting minutes. We had all of this other information. That is not necessarily the case for all of our private institutions. There's some basic information that's publicly available, like who's on your board. I can find that on anybody's website. So we're trying to find this balance here, because at the end of the day, I'm not operations of a hospital, but I do have a contract, right? It's a contract. So I got to go by what the contract says, and are we doing what the contract says? And so, and provide to the investment that we've made. Ms. Lockridge, thank you so much. I don't have any further questions. Councilmember Trayon White had to jump, but he'll probably.
I'm still here.
Oh, I didn't see you. Okay.
Yeah, I just want to make a quick comment, because one of the things I was here on the council when we started talking about the conception of this hospital and where it needed to go and what we needed was about the specialties that was supposed to be offered. Those yet, and it's been a year. And I just want to put this on the record. Like, we need to get those specialties up and running at the hospital. Didn't know if you, Ms. Hill Lockridge, spoke to on the board or where we are to that. And we can ask the leadership of the hospital as well. But you have any thoughts on the specialties that are supposed to be offered that's not yet offered yet at the hospital?
Well, I do know that there have been a number of specialties that they have been saying that they are going to roll out. Where they are in terms of overall, as you all know, the Black maternal health crisis is near and dear to my heart, and that labor and delivery OB space I do know that they are doing tours of the maternity space and understanding now. So I am hearing that there are some specialties up and running, but I don't know the extent of where they are in terms.
Thank you. I just also wanted to note that whatever the conflict is between UHS, GW is really hindering the progress of getting a high quality healthcare service in DC, you know, and I just wanted to put that on the record as well for you, Chairwoman Henderson, so we can just kind of dive into that at some point.
Councilmember White, if you just wait, the next panel has all of the individuals that you were just talking about.
Okay.
All right. Thank you, Ms. Lockridge. So we're going to go to our next panel. Jason Barrett, DC Region Group VP for Universal Health Services, Kimberly Daniels, CEO of Cedar Hill Regional Medical Center, William Elliott, who's the CEO of the Medical Faculty Associates, and Dr. LaQuandra Nesbitt, who is the Executive Director of the Center for Population Health Sciences and Health Equity at the George Washington University School of Medicine. Okay. Is you're providing, or Mr. Barrett, you're not doing testimony, you're just here to answer questions. Is that correct?
That's correct.
Okay, ready. Oh, hold on one second, because you're a little shorter than everybody. You're gonna have to pull the mic towards you, just so we can hear you. There you go.
All right, thank you. Can you hear me okay?
I usually have to advise witnesses to sort of just hug it a little. You just got to get close to the table. There we go.
Is this better?
Much better.
All
Yeah,
right.
there we go.
Wonderful. Good morning, Chairwoman Henderson and members of the Committee on Health. Thank you for the opportunity to discuss Cedar Hill's progress, current operations, and plans to expand access care for residents of Ward 7 and 8. My name is Kimberly Daniels, and I serve as the Interim Chief Executive Officer of Cedar Hill Regional Medical Center, a role I assumed in late January 26. As noted in our letter, we share the council's and the community's expectation that Cedar Hill operate at the highest level of quality and performance. We also understand the history of healthcare in East Washington and the reasons for strong community interest and at times skepticism. Of our first year, particularly public engagement, fell short of expectations. We are making the necessary adjustments and are committed to building a strong and transparent partnership that improves for generations to come. Like many new hospitals, our first year involved a learning curve. I am pleased to report is integrated into the district's hospital ecosystem more quickly than anticipated. Based on emergency department volume, we are already operating at a competitive level with long-established hospitals. Cedar Hill has effectively replaced United Medical Center as the primary provider east of the river, with patient volumes surpassing those of our predecessor within our first year of operation. The number of patients we serve reflects the trust placed in us, and we take that responsibility very seriously. We are especially proud to have restored maternal health services east of the river, filling a critical gap that has existed since United Medical Center closed its obstetrics unit in August of 2017 and permanently ended those services later that year. Today, families in Ward 7 and 8 once again have access to safe, high-quality maternity care close to home. This represents a meaningful step forward in advancing health equity in the district. To provide additional context, Cedar Hill now operates one of the busiest emergency departments in the district, with visit volumes exceeding those of several established hospitals. Our patients also present with higher levels of clinical complexity, reflecting long-standing disparities in health outcomes in the communities we serve. These realities require more intensive staffing and care, and we are continuing to evolve our approach to meet those needs. At the same time, our inpatient admissions are strong and growing. Cedar Hill averaged 359 admissions per month from July through December of 2025, compared to 228 during the same period at United Medical Center in 2024 and an average of 281 in 2023. This growth reflects strong patient demand and confidence in the care we provide, as well as effective operations that can meet and sustain higher inpatient volumes. It demonstrates that a well-run hospital can not only replace prior capacity, but exceed it while delivering consistent, high-quality care. Importantly, this growth is supported by a broader, coordinated system of care. As shown in our urgent care data, Cedar Hill's Urgent Care Center has consistently served between 1,100 and 1,900 patients per month since opening. Cedar Hill is not just a hospital, it is an emerging system of care. Urgent care absorbs visits that might otherwise present in our emergency department, allowing the hospital to focus on higher acuity patients and deliver better, more efficient care overall. Together, these services expand access, improve patient flow, and ensure that residents receive the right level of care at the right time. Despite this progress, we recognize there are ongoing challenges, and I would like to address a few directly. There are 4 issues that I want to address here that have been highlighted in the public. The first is accreditation. Cedar Hill followed the standard process for new hospitals seeking Medicare certification and Joint Commission accreditation. After obtaining licensure and beginning operations, we underwent a comprehensive and unannounced survey conducted by the Joint Commission. This included detailed records, clinical practices, and operational standards. Cedar Hill achieved its accreditation on September the 4th, 2025. The second issue is that of staffing. Like hospitals across the region, we have faced staffing challenges, particularly in nursing and specialized roles. While conditions have improved, the labor market remains competitive. We are continuing to invest in recruitment, retention, and workforce development to maintain high standards of care. To strengthen our clinical workforce, we are in advanced discussions with the George Washington University and its medical faculty associates regarding a potential transition of physician employment in clinical operations. We expect this to enhance staffing stability and expand access to care at both Cedar Hill and George Washington University Hospital. At the same time, since March 1st, we have established contractual relationships with several community physicians across primary care, cardiology, pulmonology, nephrology, and surgery, and we anticipate continued expansion of these efforts moving forward. We are also building local workforce pipelines. Cedar Hill participates in the DC Hill Apprenticeship Program and partners with City Works DC and the Department of Employment Services. Through these efforts, we are training and hiring district residents and building a sustainable workforce rooted in the community we serve. We currently have approximately 574 full-time equivalents on staff and have exceeded our hiring commitments regarding district residents in every category except pharmacy technician. We are actively recruiting to fill vacant nursing positions, a challenge shared by providers across the region. At present, we have approximately 67 RN vacancies, which are being covered by nurse staffing agencies. We are optimistic that our efforts will yield positive results in the future. I'm at Cedar Hill. I have seen a team that is deeply committed to delivering high-quality care, and it is truly my honor to lead such a group of dedicated professionals. The third issue is that of the emergency department. Cedar Hill has scaled its emergency department quickly and effectively with utilization levels that reflect strong community demand. We recognize that there were challenges early on, particularly as demand exceeded that of United Medical Center. We remain focused on continuous improvement. We have made meaningful progress in reducing wait times and improving patient flow, including reductions in patients leaving without being seen. Over the past 6 months, the median wait time from patient arrival in the emergency department at Cedar Hill to physician evaluation has been 48 minutes. While there is still considerable room for improvement, this performance is comparable to hospitals across the district. A 2014 analysis conducted by the Milken Institute School of Public Health at the George Washington University reported an average wait time of 46 minutes. With respect leave in our emergency department without being seen. Since October 2025, an average of 3.6% of our patients have done so, which is well below the 6% national average reported by CMS in 2024. Nevertheless, our goal is to ensure that every patient has a positive and timely care experience and remain committed to further improving these outcomes. Looking ahead, UHS is developing a freestanding emergency department in Ward 7, scheduled to open in December 2028. While initial timelines anticipated an earlier opening, delays related to site readiness that are out of our control have shifted that schedule. This facility, combined with our urgent care center and planned outpatient clinics, will further strengthen our system of care by expanding access points and reducing strain on the main hospital. Finally, community engagement. Cedar Hill is committed to consistent and transparent engagement with the community. In 2026, we are expanding our community programming to address longstanding health disparities. We plan to convene both the community and the patient family advisory committee in the coming months. We will also submit our first annual quality report by the end of May 2026, reflecting a full year of operations. In addition, we welcome ongoing engagement with the council and district leadership to provide regular updates on our progress. The last issue is that of the immediate jeopardy. I want to briefly address the immediate jeopardy citation issued a few weeks ago, as there has been significant misinformation about this matter in the public domain. During a February 23rd, 2026 survey, Cedar Hill was cited with an immediate jeopardy finding based on DC Health's finding that the hospital failed to ensure timely provision of surgical services for a patient. Notwithstanding, Cedar Hill leadership implemented immediate corrective actions, and DC Health lifted the IJ finding the very next day on February the 24th, 2026. An immediate jeopardy is a citation issued by a surveying agency at one or more specific areas in a hospital, which requires immediate corrective action. The entire hospital was not found to be an immediate jeopardy institution, nor designated as an immediate jeopardy hospital, as some have incorrectly stated. There was merely one area, surgical services, where the surveyors in their subjective view determined the situation met that criteria. As stated, the deficiency was remedied in one day and the immediate jeopardy finding was lifted. The hospital is not in jeopardy of closing due to this issue. Further, contrary to false claim that only a tiny number of facilities have received an IJ finding in the country, immediate jeopardy citations, while unfortunate, are not uncommon. In fact, in the past 5 years, there have been almost 700 immediate jeopardy citations at hospitals nationwide, including many well-respected and well-known national and local institutions. Cedar Hill Regional Medical Center remains committed to upholding the highest compliance with all regulatory requirements to help ensure the safety and trust of our patients and community. When deficiencies are noted, an occurrence that happens at all hospitals, immediate remedial actions are implemented to alleviate any such matters. In conclusion, please know that the entire Cedar Hill team and I are fully committed to building a hospital that delivers high-quality care, earns the community's trust, and makes the district very proud. I look forward to working in partnership with you to continue this progress. Thank you, and I'm happy to answer any questions.
Thank you. Mr. Elliott.
Good morning, Councilmember Henderson, members on the Committee of Health, and fellow invited guests. My name is Bill Elliott. Serve as the Chief Executive Officer of the GW Medical Faculty Associates, or as we commonly refer to it, the MFA. I have more than 2 decades of administrative experience leading high-performing multi-specialty academic faculty group practices. I take the invitation to participate in this roundtable on Cedar Hill. The subject of today's discussion is critically important to me and my organization of more than 500 physicians physician assistants. The MFA is a nonprofit physician group practice made up of the academic clinical faculty of the GW Medical School. We are the largest independent academic physician practice in the DC metropolitan area. Currently provides comprehensive care in more than 50 medical and surgical specialties to patients at multiple locations around Washington, DC, Maryland, and Virginia. With George Washington University School of Medicine and Universal Health Services to provide innovative, high quality, and equitable clinical care to global national communities. Importantly, MFA physicians live and work in the communities they serve. Nothing is more important to these professionals than ensuring that all individuals of circumstance, status, or zip code have the very same access to quality health care that they provide. Many of them became physicians and chose to work for the MFA because of their unyielding belief and dedication to. In connection with the focus of today's roundtable, I start by highlighting MFA's distinct role at Cedar Hill. The MFA is responsible for providing physician and advanced provider staffing at Cedar Hill Regional Medical Center and the Ambulatory Care Center, both of which are operated by nurses. These two distinct locations, the hospital and the Ambulatory Care Center, represent separate spheres of responsibility for the MFA. Each location is governed by different agreements and places different staffing responsibilities on the MFA. Each location, pursuant to our contract, UHS sets the number of physician and advanced practice provider staffing it wants at the hospital and the Ambulatory Care Center for specialty services. The MFA then works to meet those numbers. Under this agreement, the UHS the MFA must either 1, supply the physicians requested, or 2, inform UHS that it is. This notification mechanism allows UHS, as the operator of both the hospital and the Ambulatory Care Center, to identify community physicians or locum tenens to ensure appropriate coverage. At all times, the MFA followed this process, physician and advanced practice provider staffing at both locations. To be sure, challenges existed, continue to persist, but Cedar Hill Hospital was fully staffed with physicians since the opening of April 2025. And as early as July 2025, the MFA was ready to support the Ambulatory Care Center with 9 service lines. UHS did not open the center until December of 2025. At that time, MFA provided physician staffing to support 6 service lines UHS decided to maintain at the opening. I am honored to participate here today because the objective of this roundtable is to chart collectively the future of Cedar Hill so it may live up to its promise. Achieving this objective is more important to the MFA because it is made up of physicians about the patients they serve. Our physicians have a steadfast belief in the principle that all individuals deserve access to quality health care. They have devoted their careers to bringing this principle to life. Our physicians work very hard to ensure Ward 7 and 8 have access to quality health care, including by serving patients at both Cedar Hill Hospital and the Ambulatory Care Center. When I prepared for today's roundtable, I reviewed the MFA's history of physicians at both Cedar Hill Hospital and the Ambulatory Care Center. This history allows me to make 2 important observations. First, the MFA worked in partnership with UHS, Cedar Hill, to ensure that a combination of MFA clinicians, locum tenens, and community physicians provided the necessary complement of clinicians necessary for hospital operations when it opened in April 2025. As you know, securing the necessary physician staffing is a process, and part of that process for particular specialties or subs, the MFA was confronted with challenges. For example, OBGYN, general surgery, and nephrology. The MFA notified UHS that non-MFA clinicians were necessary to support operations at the opening. This challenge arose in part due to the unique recruiting timeline for physician roles. Specifically, recruiting for an April start date is a challenge because most physician contracts start in June of each year, given the operation of academic calendars. As a result, it took longer than the MFA had hoped to identify and recruit high caliber performers for these specialties and subspecialties. This recruiting process, which can take up to 2 or 3 years in some cases, is the same one we use at GW Hospital. We use the same recruiting process because patients at Cedar Hill deserve the same quality of care as patients at GW Hospital. UHS and the District of Columbia agreed to this principle in the operating agreement. When I describe this challenge, please know that it did not result in any physician staffing shortfall at Cedar Hill Hospital. To the contrary, prior to opening in April 2025, the MFA notified UHS of these recruitment challenges for particular provider specialties and subspecialties. UHS then worked very hard to ensure that any of these identified gaps were filled by a combination of locum tenens and community physicians when the hospital opened. As an epilogue, by June of that year, the MFA had found permanent physician staffing for almost all specialties. Through the UHS and MFA partnership, Cedar Hill Hospital has maintained sufficient provider staffing since its opening. The second observation I make is that at the request of UHS, the MFA began providing Physician Statutory Care Center in December of 2025. The MFA worked throughout 2025 to prepare for the center's opening and had the staffing and financial support available to act when called upon. Any suggestion that financial issues or economic difficulties impeded the MFA's ability to provide necessary physician staffing at either the Ambulatory Care Center or Cedar Hill Hospital is simply incorrect. It's wrong. The MFA has consistently received financial support from GW that allows it to provide the necessary high-quality physician complement at both facilities. While the MFA is currently providing physician staffing for 6 service lines and growing as requested by UHS, our physicians and advanced practice providers remain at the ready to serve Cedar Hill. And that availability, that readiness is emblematic of MFA's efforts to serve Cedar Hill community in partnership with GW, UHS, and the District of Columbia. We remain committed to acting with diligence, transparency, and open communication. I look forward to our discussion. Again, thank you for the invitation to address you today.
Thank you, Mr. Elliott. And Dr. Nesbitt, welcome back to the table.
Thank you. Good morning, Chairperson Henderson and members of the Committee on Health. Thank you for the opportunity to testify today regarding community engagement, education, and training programs at Cedar Hill Regional Medical Center. My name is Dr. LaQuandra Nesbitt, and I serve as Executive Director of the Center for Population Health Sciences and Health Equity and Senior Associate Dean at the George Washington University School of Medicine and Health Sciences. I am pleased to share how our work at GW reflects a deep commitment to community partnership, health professional education and training, and improving health outcomes for residents of our community. At the George Washington University School of Medicine and Health Sciences, at the core of our shared values is the understanding that meaningful, sustained community engagement is essential to improving health outcomes. It goes beyond consultation with community. We are building structures that position community members, service providers, and patients as co-creators of health solutions. GW has established a formal, structured approach to community engagement, contractual responsibility to support population health research and respond to community-identified needs. At the outset, I would like to briefly explain the commitments GW respect to Cedar Hill as set forth in the Cedar Hill Professional Services Academic Affiliation and Research Agreement between GW, the Medical Faculty Associates, Universal Health Services, and Cedar Hill, or the CHA for short. Under this agreement, GW agreed to utilize its expertise as an academic medical enterprise to develop research programs related to addressing the underlying conditions leading to health disparities for community residents. We also agreed to implement community-based outcomes and population health research for patients with chronic and/or complex conditions and support additional health needs identified in the district or UHS's community health needs assessment. GW also agreed to develop and/or expand residency and fellowship programs, develop a new family medicine residency program, and provide students, residents, fellows, and interns for patient care activities. In 2023, as part of this undertaking, we launched the Cedar Hill Alliance for Health Equity, a community-centered initiative designed to bring together residents, community-based organizations, clinical providers, and GW faculty and research staff to work together in interdisciplinary teams. the Alliance ensures that the lived experiences, preferences, and priorities of the community directly inform how care is delivered, how defined, and how population health research areas are prioritized. Since its launch, this work has translated into tangible action, including community engagement programs at GW's Cancer Center located on the campus of St. Elizabeth's and GW's Center for Global Mental Health Equity, training over 24 community providers in evidence-based interventions to support behavioral health. Importantly, our engagement efforts are ongoing and evolving. As part of our sustained commitment to shared decision-making and accountability, GW is currently leading a new community-driven health needs assessment titled, "What Would You Like to Be True?" This initiative invites residents to identify not only health challenges, but also their vision for healthier communities. Through facilitated discussions and workshops, residents are helping map root causes of health issues and co-develop solutions that will inform a community health improvement plan. However, implementation of that plan will require sustained funding. At present, there is no identified dedicated funding stream to support execution of this community health improvement plan. Without that investment, the impact of community engagement efforts GW had envisioned spearheading will be limited. In addition to community engagement, our partnership at Cedar Hill reflects a strong commitment to building a diverse, community-responsive health workforce. Under our agreement, GW serves as the exclusive partner for education and training programs at Cedar Hill, spanning medical students, residents, fellows, and allied health professionals. We have made meaningful progress in designing an interprofessional education model that brings together medical students, physician assistant students, nursing students, and other trainees. This model emphasizes team-based care, aligns training needs with real-world clinical environments, and prioritizes patient-centered care while supporting learners. Our goal is to prepare a workforce that is not only clinically excellent, but also equipped to address the complex health and social needs of the communities they serve. Another key component of the interprofessional education vision is the development of a family medicine residency program intended to address the critical shortage of primary care providers in wards 7 and 8. Areas designated as medically underserved. Over the past 2 years, we have taken several foundational steps. We have established a joint committee with hospital partners to guide planning, conducted detailed assessments of accreditation requirements and financing pathways, reestablished the Department of Family and Community Medicine to support the program, and initiated partnerships discussions with community-based health centers to ensure adequate training sites for continuity of care. However, despite this progress, the development of the family medicine residency program is currently paused due to uncertainty regarding sustained funding support. As you know, graduate medical education programs require stable, multi-year financing to support faculty, residents, and educational and clinical infrastructure. Without institutional or partner investment to bridge the period prior to federal funding, these programs cannot move forward. In closing, I want to emphasize that GW's work in wards 7 and 8 reflects a broader commitment to advance health, strengthen communities, and build a health professional workforce that meets the needs of the district. As we stated when Cedar Hill first broke ground and when the hospital opened, we believe Cedar Hill has the potential to dramatically improve health outcomes and reduce health disparities in wards 7 and 8. Based on our academic experience, 3 factors are key to success as we move forward. First, community engagement must be resourced to be effective. Planning processes alone are insufficient without funding to implement community-identified priorities. GW has demonstrated that authentic community engagement is not only possible, but essential to improving population health. We have launched population health research and community health programs and created pathways for innovation grounded in community voice. We have built the infrastructure, partnerships, and program designs necessary to continue to implement research programs related to addressing the underlying conditions leading to health disparities for community residents and for those living with chronic and/or complex conditions. Second, workforce development, particularly in primary care, requires upfront investment. The absence of funding for residency programs will perpetuate provider shortages in medically underserved areas. At the same time, realizing the full promise of Cedar Hill Regional Medical Center as a hub for training and care will require sustained investment in undergraduate medical education, graduate medical education programs, and allied health. Third, alignment between hospital operators, academic partners, and public stakeholders is essential. Fragmentation in funding or strategy directly limits the ability to deliver on the intended mission of Cedar Hill Regional Medical Center. Irrespective of funding from UHS, GW remains committed to working with the council and our partners to ensure that Cedar Hill Regional Medical Center achieves its intended role as a high-quality, community-responsive teaching hospital serving the residents of Ward 7 and 8. Thank you for the opportunity to testify, and I welcome your questions.
Thank you. Thank you to this panel of witnesses. We're going to do 10-minute rounds, try to be efficient. Okay. Let's see. We'll see. Okay. Thank you all. Let me say at the outset, thank you for being here. Also, thank you for the meetings that we've had prior. I'll let you know too that I've read every report that DC Health has done, inspections of Cedar Hill. And so that goes into a little bit of our questioning as well from the regulator. So the hospital operations agreement clearly assigns responsibility across UHS, GW, and the MFA. From your perspective, has coordination broke down? How often are the three entities talking to each other about the operations of the hospital?
I guess I'll dive in. The water's warm. First and foremost, good morning. I'm Jason Barrett. I'm the Group VP for the DC region with UHS. Yes, we meet quite often. And as you, I think to give further context and be thoughtful about the answer, and certainly I would invite my colleagues to speak to this. As public record, we're in real in-depth conversations about the acquisition of the MFA by UHS. And just by way of background, I think you recognize that the university made a decision last January that, you know, the financial strain was undermining or largely their academic mission. So we have been working in concert with the university and the MFA in structuring this transition, you know, and I think it goes without saying that this is a very large acquisition.
It is. And Mr. Barrett, I don't want to cut you off,
Sure.
but the acquisition of MFA and UHS is actually not my concern for today's hearing. It's really around the operations of the hospital and the three entities working together on that.
No, I understand, but
Okay.
that protracted negotiation has played a direct role in the operations of the hospital.
Okay.
Hence why I was giving background. And to the point of we're in a spot where the MFA was losing $100 million a year. That's after $110 million worth of funding from UHS. So we are in a position, and I believe the broader point I'm making here is that the three parties, really four parties if you include the district, have been working in concert. I will say the protracted negotiation has impacted the operations. However, I feel very bullish about where we are now. I think we're at the 11th hour of coming to an agreement, which will not only sustain operations at Cedar Hill, but for the broader district.
Okay. Well, then let me ask you this way, since we're going to talk about it. I wasn't planning to, but since we are. Mr. Elliott, your testimony says that what has been happening in terms of the negotiations between GW, MFA, and UHS or the university has not impacted staffing, correct?
Physician staffing, that is correct.
Okay, so Mr. Barrett, then how has that impacted the operations if staffing has not been impacted?
Well, and I have a dear, affinity for Mr. Elliott, so I will just simply say this. I disagree with the assertion, and that's borne out. There's a difference between readiness and sustainability.
Okay.
And that's borne out by the use of locums.
I didn't want to talk about it today.
I know.
All right.
I was just asking you a question.
Things I want to talk about. So, okay. Who picked the opening date for Cedar Hill? Anybody remember? I know most of y'all weren't there, but
That predates me.
who picked April? Seems an interesting time, given Mr. Elliott's testimony, that April creates a challenge in terms of recruitment, given that June is usually when we do physician acquisitions in terms of aligning with the academic year. Anybody remember? Okay. Dr. Nesbitt, I think you may have still been with district government when the hospital operations agreement was initially signed. Is that correct?
I was, but I was also managing a public health emergency.
Okay, who wrote the agreement? Which agencies were engaged in that?
Mostly the city administrator's office, I think, was the lead for most of the activity at that time.
Okay. Right. Okay. There was a February report from DC Health that reads in part, Chief Operating Officer confirmed that a planned 16-bed medical surge unit was not open. It is worth noting that this unit had 16 licensed medical surgical beds, but has not been used since the hospital opened. How many bays or beds are we currently operating with now?
We have 48 med-surg beds that are currently operating and open, 20 ICU beds that are currently operating and open.
Okay. There were a number of instances in some of the reports from DC Health that talked about lack of documentation for hospital protocols, such as medication administration, wound care, suicidal ideation assessments, and blood pressure readings. I know that you all have been using a lot of travel nurses. What does onboarding look like when you're bringing on a travel nurse to ensure that they are complying with the protocols that have been outlined?
Sure. So initially, when they're onboarded, they come into a one-day orientation. During that one-day orientation, they learn about the basic hospital policies and procedures. The second and third days, they're taken directly into a skills training. And in that skills training, we're assessing the competence that they have the appropriate skill set to administer basic nursing care. In addition to that, we have educators on board who are providing ongoing training. When they get to the unit, the expectation is that they would have elbow-to-elbow support by the educators who are dedicated to those specific units.
Okay. So I'm assuming the educators are permanent staff?
The educators are permanent staff, yes.
Okay. Is there any situation in which a house supervisor would be a travel nurse?
There should not be an instance where a house supervisor is a travel nurse.
Okay. How or at all are clinical staff currently shared between Cedar Hill and Foggy Bottom?
Currently, there are no clinical staff. We do not share nurses. We are in the process of establishing a central pool for imaging, which is an ancillary service. But beyond that, we're not sharing team members.
Okay, so anesthesiologists, Cedar Hill has their own?
Cedar Hill has their own group of anesthesiologists. That is correct.
And for surgical techs as well?
That is correct.
Okay. Are they often all on call?
So we have our surgical techs who are on call, but during the on-call time, they are actually in-house overnight. We have on-call rooms where they are spending the night.
Okay. I've had a conversation with Children's. They're not testifying today, but I understand some of their particular awareness of the public. The relationship at UMC, Children's, when they were operating there, provided both their physicians as well as their nurses and their techs. My understanding is at Cedar Hill, they are only providing the physicians. Are you all in the process of revising that agreement with Children's National?
No, we are not.
Okay. Are we addressing some of the staffing concerns that Children's has raised?
Yes, we are. So we have a joint operating council between the leadership at Cedar Hill and the leadership at Children's National. Through that, we are working through some of the issues of quality. We're working through the issues of staffing. We're working through the issues of communication, and we're working through the issues of the operations and the finances.
Okay. Let me talk a little bit about the board for right now. Who picked who was invited to join the board at Cedar Hill?
Unfortunately, that predates me, so I am unsure of who was selected.
Okay. Do you
Who
all
made the selections? Excuse me.
do you all consider the board of Cedar Hill to be governing or advisory?
I consider it to be advisory.
Okay. So I read the hospital operations agreement. When did that change become made, and did anyone inform district government of this change?
So if I may, this is almost term of art because the board of directors is UHS's board. So that's when dealing with indebtedness, that deals with sale of facility, that deals with, deploying capital, things of that nature. That is the board of directors. The board of governors throughout all UHS facilities is advisory. So they oversee medical staff bylaws, they oversee quality and safety, patient experience. So there is a distinction, almost term of art, I apologize, but that's how we frame it. And I came from a long time ago, it was a different board of governors and board of trustees had a different meeting.
Right. So is the board at GW University Hospital advisory?
Yes.
Okay. Interesting. Are you all comfortable with who's on the advisory board for Cedar Hill? I would tell you one of the things that was distinct and noticeable to me in sort of comparing the two is that multiple chairs of the faculty at GW Med School, nursing school, school of psychiatry, they're on their board. When I look at the list, at least the one that I have of the board of Cedar Hill, I think there's might be only one person who has a medical background.
Well, and again, I'm not trying to be evasive, but in the structure of it, what we have and how the folks came to be, the current makeup is 80% UHS, 20% district, and that can be a selection, whether it's MDs, which we have on the GW board. But we do want it to be more community facing. And what we have and how the folks came to be, the current makeup is 80% UHS, 20% district, and that can be a selection, whether it's MDs, which we have on the GW board. But we do want it to be more community facing. And, and I think that we've heard that from, certainly our council members. It's a better representation. I think there was a little bit of replicating kind of a GW model at Cedar, and it's distinctly different. As someone who's run community hospitals for 30 years, it's distinctly different.
But I would say, as someone, again, I wasn't here at the beginning, but this idea that it was just going to be some community hospital. It was supposed to be a part of a network and a system, and care. They wanted a hospital that is at the same caliber of GW, Sibley, MedStar, Georgetown, et cetera, right? So yes, we're making comparisons because we have to make comparisons. Matters from any sort of board structure, right? I deal with boards for charter schools when it's great to have community members on, but when they don't have background in finance or things, it impacts the questions that they ask, and it impacts how they provide input in that. But I'm well over my time. Councilmember Parker.
Thank you. Mr. Barrett, I'm going to start with you. What, if you could level set for us in a 10 to 15 second headline, what is the relationship between Cedar Hill, UHS, and GW in your view?
Well, we were partners, certainly. And Cedar Hill is, obviously a partnership with public-private partnership with the city. GW is and the MFA are academic and clinical providers. So it's a partnership. It's a complex one, as you can imagine. And I think that, if there is a broader optimism, not only for Cedar, but for the broader district, is this alignment with the MFA coming under UHS will allow us to align strategic initiatives. Because as a Fortune 300 company, we'll have the balance sheet to support their sustainability.
And just quick responsibility, and I don't mean this as a got you question, but there are clear challenges at Cedar Hill. At what point do those challenges become the responsibility of GW and or UHS to step in more aggressively to meet those challenges?
Well, I won't speak for my university partner or the MFA. I will simply say that, any greenfield hospital, it takes some time for liftoff. Now, no one's taking away that this was not the launch that we wanted. I think that we have been working more collectively now. And again, for the chairwoman, the reason I brought up the structural nature of this and the economic integration, it was fundamental to our ability to provide the type of care that the citizens in Ward 7 and 8 deserve.
Understood. What is the plan to establish or identify a permanent CEO at Cedar Hill? And let me just say, Ms. Daniels, I've heard nothing but glowing reviews, and I'm not just saying that because you're sitting here. I've heard that from folks at Cedar Hill, folks out in the community, but knowing that you're toggling between GW and Cedar Hill, what is the plan for permanent leadership?
Well, we are in the process. The job is posted. I think that we're in a position where we are very proud of our pipeline within UHS and promoting within. Certainly, I think the watchword for Cedar has been stabilization. I would say Ms. Daniels has done a wonderful job in that role.
Can you give me a window of time? Next 6 months?
6 months.
6 months. You're hoping to have a new CEO. In your view, Mr. Baird, what are the top priorities to turn the hospital around?
I think, there's certainly quality and safety is always your job number one. But I would also point out that we have to build an ambulatory network. And that's why the partnership with Unity and Community of Hope and our community providers is so critical. Much of what we do today is largely based on the ED, and we've improved there under Ms. Daniels' leadership. But I would say that, again, and then also the stabilization of workforce, which every healthcare provider is dealing with, building a team. Hospitals are more than bricks and windows. It's a culture, it's a soul, and it needs to represent that community.
So safety, ambulatory services, staffing, generally
Correct.
Are key priorities.
Yeah.
Ms. Daniels, I wanted to come to you. I appreciated you noting the work that is going into tackling long wait times and ER operations. What are your plans for continuing to improve the efficacy of the emergency department at Cedar Hill? In your microphone.
First is to stabilize staffing and leadership. We just brought in a new ED director who has a number of years of experience across the country.
Sorry to jump in.
Sure.
What number leader is that for the emergency department?
I believe it's the second.
Okay.
I believe they previously had an ED director. That role transitioned, I want to say, in the fall of last year. And so this would be the second ED leader.
Okay.
And the second ED leader, I think there may have been an interim in between the two. So third, if you count that.
Okay.
Yes.
Yeah, it's in my notes I have that there's been three we're now on our third leader.
Yes.
A follow-up question I have is, how are those leadership changes contributing to the inefficiencies that we're seeing play out in the emergency department?
Admittedly, I do think that it doesn't allow us to stabilize in the way that we need and build a consistency around meeting certain metrics. You mentioned earlier the offboarding times from the ambulance, improving the wait times, improving the left without being seen. And so I think that it impacts operations in that way. Now that we have a solid team and we have the leadership, not only do we have the ED director, but we also now have a permanent chief nursing officer, has worked at Washington Hospital Center, very familiar with the DMV, has over 13 years of experience, and so works and has worked in this community and is very familiar. I believe that we are significantly stronger than we have been in the past, and we are on the path to success in righting the ship in the ED. I think what you will see is continuous improvement.
In terms of strengthening staffing, what's the plan to bring on more community physicians? We heard earlier that there's a backlog. Folks are applying, they never hear back. What would be your response to that?
Yes. So first, I'd like to say that we've done a lot of work in the last 8 weeks that I've been here. We've brought on family and community medicine, Dr. Daniel Moore. He is in our ambulatory operation 5 days a week. He's seeing patients anywhere between 40 to 60 patients per day. We've also signed on Dr. Julian Cray, who is a pulmonologist, who is starting with us. We also have cardiology signed on, but wants to start in July 1st, I believe it is.
But we heard earlier there's at least 12 people who have applied who've never heard that.
And so my goal is to kind of go back and understand who those individuals are. In my experience, I am not aware of who those 12 individuals are and what the backlog would be, but I am more than happy to go back and research that. I can tell you that I did personally meet with all of those community physicians twice as a group and individually, one-on-one, except for 4, walked through the entire process of how they could partner with us based on what their intention was, whether it was to become employed or whether it was to become simply just to have privileges or to so I am not aware through those discussions or currently of any backlogs that have impacted their ability to move forward in the process, but certainly happy to follow up.
Okay, so if folks are waiting for a response,
they should call
maybe
me.
They should call or reapply.
No, they should call me, but I will do a warm touch and I will proactively reach out to each of them.
Understood. Can I ask about compensation? How does compensation for physicians and staff compare to other hospitals in the region?
So I'll have to defer that to Mr. Elliott.
And the reason why I'm asking that as you come on, in what ways is that contributing to our staffing challenges?
I can speak to the physician component of that. And we have a market standard schedule that we use when we recruit that is fairly competitive in the market. So I don't know that the physician side of the recruiting piece, the salary component, has been a major obstacle.
Would the average physician at GW or some other institution match the compensation at Cedar Hill?
It's actually a little bit more at Cedar Hill because it's not an academic facility, so there aren't the residents there and there aren't the actual support. So the schedule at Cedar Hill is actually a little more.
Okay. And what about the other staff? What I've heard is that compensation is a challenge for folks to sign up to come to Cedar Hill.
Yeah. So I can tell you specifically with nursing, the compensation for nursing at Cedar Hill is higher than the compensation at GW. We offer an incentive plan, of a +6 per hour for each hour that the nurses are worked on top of their base salary, which puts them significantly over what the nurses are making at GW.
Time in this round. What information can we see in that quality report, Ms. Daniels, that you're producing by the end of May?
So we are looking at all of our nursing indicators that would allow you to see kind of how we're performing with each event. Things like our falls, our mortality rate, our infection rates, hospital-acquired pressure ulcers, so on and so forth.
And is that report comparing Cedar Hill against itself? Will I be able to review that and see how Cedar Hill is stacking up against other institutions?
Yes, this was a public report. You will be able to see not only how Cedar Hill is stacking up in the local market, but nationally as well. So this is a report that is benchmarked against national data.
Understood. Okay, thank you.
You're welcome.
Councilmember White.
Yes, thank you. I guess I'm gonna start with you, Dr. Daniels, with the first round of questions. How much did Cedar Hill lose last year? How much is being lost on a monthly basis? And I guess thirdly, what is being done to get us going in the right direction?
Okay. So first, Councilman White, I appreciate you promoting me, but I am not a doctor.
Okay, but there it is.
I just wanted, I don't want that on the public record. But last year, Cedar Hill lost, I believe it was about $54 to $60 million.
And when I met with you guys were citing some of that to getting started, getting everything done, being behind. I guess my next question is what is being done to turn that around so we can eventually be profitable?
Yes. So it is all the work we're doing from an operations perspective to build access. That is our greatest opportunity. Our main entry point right now has been the emergency department, and we need to have more of a comprehensive build. We need to really focus on bringing in elective surgeries and elective cases into the environment. And so that is what our focus is.
All right, thank you. I would like to follow up on that later on because I have not heard something concrete that helped us get it where we need to be. It's just generalized statements. I guess I know that you all reported at some point you were short 67 RNs, had 67 vacancies, and wanted to get those filled. Are those filled yet?
So those are not permanently filled. We're using travel nurses to fill those positions. So yes, we have bodies in those roles, but they're with travelers and not with permanent positions. We're currently recruiting to fill those roles permanently.
I know there was an agreement that was between a community-based organization, Out of Time organization, and GW originally about they were training nurses. Do you know if that relationship is still ongoing? I know they were training in Ward 8 under Miss Tanya Ridley. Are you familiar with that?
I am not familiar with that, but happy to follow up.
Okay. I do have a question. I want to jump to Mr. Elliott as relates to staffing. You stated in your testimony that Cedar Hill was fully staffed in April 2025. I'm not sure if that's the correct statement. This goes against what I've seen and heard from the community, from being in meetings, particularly as it relates to specialty physicians. Can you give some more information on that?
We're happy to. So in April 2025, we were fully staffed with the startup staffing roster that was provided to us. Other than, from the MFA perspective, the ones I mentioned, the OBGYN, surgery, and nephrology. But working with my colleagues, we were able to fill those with locum tenens. So we were able to meet the needs of the community starting in April 2025. So we did have enough physician staffing. I can't speak to the other support staffing.
How many staff vacancies do we have in the executive level and at the, I guess, under the executive level currently at the hospital?
So at the executive level, all of our C-suite positions are filled with permanent leaders.
And all other staff?
Except for the CEO role.
What about all other staff?
All other staffing, are you meaning director level?
So the reason why I'm asking is because I get, I've contacted you a few times, even prior to your leadership. I get so many people contacting me saying I applied to the hospital. I'm getting no answer. I'm getting no call back. And then recently you all put out saying you all doing a job fair, but had a few hundred applicants, maybe 1,000, I'm not sure. That's what I'm asking, how many of those positions have been filled? Because at one point, you all were short 500 staffers. I'm not sure what that number is now. That's what I'm trying to get to the bottom of.
Yeah. So we have about 570 against a budget of about 634 in total for staffing. So we have significantly narrowed the gap from a staffing perspective.
And this is the 634 positions, I think you said, to cover the hospital 24/7?
That is correct.
That seems like a low number.
So you also have to consider that we have contractors who also provide services to help with the operations of the hospital.
I got you.
We have contract relationships through CBE contractors who provide services to help support the hospital, in addition to our FTEs, our hired FTEs.
So right now we have how many vacancies? 100 and what?
Let me get that number specifically. I know we have 67 RN vacancies. Let me get the number for the non-nursing vacancies.
Okay, while you're doing that, I want to jump back to Mr. Elliott. You said that any suggestion that the financial issues or economic difficulties in the MFA's ability to provide the necessary physical staff, physician staffing, at either the ambulatory care center or Cedar Hill Hospital is simply incorrect. Then I'm heard from Councilman Parker that some of the issue may be money as relates to payment. What is the breakdown into and the financials as relates to getting these doctors what they need or staff what they need to be a fully run hospital?
I can speak to the component about providing salary and compensation for the providers that we have at Cedar Hill, as well as at GW University Hospital. And we have never wavered on our commitment toward 7 and 8 in Cedar Hill, nor have we at GWUH. We do not have directly the funds at MFA, but we have had continued financial support from GW to support all of our missions. So we haven't had any setbacks or delays in recruiting or payment of physician salaries and compensation ever. To Mr. Barrett's point earlier, it is unsustainable, but it hasn't kept us from continuing operations.
At some point, there was a disconnect between the community doctors getting even ear to the hospital, and now there's been some traction. Early on, what were some of the barriers and breakdown and those community doctors getting a shot, as I may say, at working at the local hospital?
Start with that one?
You can start.
Sure. I'm happy to start with that one. And then if my colleagues want to add, they can. I had this conversation not too long ago about the community physicians and their engagement at Cedar Hill. And from the MFA's perspective, we support the use of community physicians and the engagement and participation. The only time we may have had some hesitation there in the past, we were already recruiting and had somebody who made an offer that was coming on board. We may have said, well, we already have that particular specialist who has resigned from their current job and moving their family to DC. So we may want to pause on bringing in a community physician for that particular specialty, but we support the use of community physicians certainly going forward. It can only help make the healthcare more robust.
So I hear you saying we support, but I haven't seen it materialize in reality. Even I heard Dr. McPherson Quarters say today that there has been some conversation, but then they have to start over. So support meaning how does support equals contracts? How many of those doctors actually have contracts there at the hospital now?
On the credentialing and onboarding process, I may have to defer to my UHS colleagues.
I'm sorry, can you repeat the question? I was trying to.
Yes. He was saying that Mr. Elliott was saying that there is a desire or some appetite to appease and make sure there's community-based doctors there. But it seems like it's just a desire. I don't see where the contracts are, because I did hear from the hospital based on our conversation back and forth that you are making progress. When I heard from Dr. McPherson Quarters today, she said that there were 2 doctors there, I believe, of that large number, and some didn't get contact back, and then they had to start the application process over again. So the desire doesn't mean actual contract. It just sounds like feel-good words. Where are we if actually bringing those doctors back so we can get the quality healthcare services from our community-based doctors?
Right. So we're currently evaluating 2 community doctor contracts that will allow them to come and move their practices back to the facility on a full-time basis. So in terms of the tactical work that we're doing, we're reviewing the agreement. We're making sure that we're meeting the needs, that the requests of the physician and the physician's group, as well as making sure that we're working compliantly within our contractual relationships that we have with other partners.
With how many of the doctors that were listed?
So we have 2 independent of the individuals that were in that initial community meeting group. 2 of those individuals, we are looking at their contracts specifically. Of that initial group, some of them are not choosing to have contractual relationships in that way. Some of them group. Two of those individuals, we are looking at their contracts specifically. Of that initial group, some of them are not choosing to have contractual relationships in that way. Some of them have decided to simply just lease space in our facility. I think I named about 3 or 4 of those earlier.
Over my time, Councilmember Henderson, thank you.
Thank you. Go to some of the pre-hearing questions that I sent to you all, and we'll follow up on a couple of things. So according to the responses, GW and UHS established a Cedar Hill Executive Steering Committee in February of 2023, which included GW faculty, clinicians, and UHS administrators. Committee met.
The last Wednesday in March of this year.
Do any members of the steering committee now serve on the Cedar Hill board?
No. GW has 2 appointees to the board. Medical director for hospitalist services, Dr. Juan Reyes. The other one is a nurse who lives in Ward 7 with a doctorate in healthcare administration, Dr. Sharon Lewis.
Okay. The pre-hearing response agreement seems to require UHS to work with a wider group of partners to develop and implement a community engagement plan. Conflicting. How have you all been working through this tension?
Sure. So in UHS's agreement with the district, UHS has a requirement to do population health research and implement population health initiatives that are responsive to the longstanding the residents of Ward 7 and 8 have faced. And they have to be responsive to the needs of residents in Ward 7 and 8 as the residents themselves have expressed them, and in partnership with community partners. And because GW as a university has expertise in approaching with GW for clinical services or professional services, academic affiliation, and research, they passed those requirements from the district on to GW and had a financing or financial model for that. Mm-hmm. So through and health sciences has started to do that work, population health research, but we're doing it in partnership with community convened spaces.
Okay. The Executive Steering Committee had worked through 2023 to 2024 to establish a family medicine residency program, and GW had worked to start that it wants to terminate that current academic and educational agreement and not commit to any future funding for the residency program. Now, I'm going back to how this was sold to the community, that Cedar Hill was supposed to be a teaching hospital. So why are we deciding not to move forward with residency program?
Nationwide, there's a scarcity of primary care. We are committed to primary care. But this, again, goes back to the broader discussion. GW recently was not going to fund any of their fellows. UHS took that on. So we are in a position of trying to it's going to be material impact to GW as well as Cedar. But we have every intention. I actually just spoke with the dean about a family practice residency. It's just we got to put one foot in front of the other.
Okay, so it's not dead forever. It's just postponed.
Yeah.
Okay.
So we need to be clear, however, that for the residency program, that UHS has to make those investments, that the university cannot make those investments of UHS. So we want to be clear about that.
Okay.
They're in tandem.
Okay. I'm clear in terms of how I heard it. It's on pause, but the financial responsibility for unpausing would be on UHS in terms of movement forward. Is that accurate? Correct. Okay. All right. There was never mind. I'm going to move on. Okay. Ms. Daniels, you mentioned in your response, I think to Councilmember that Foggy Bottom. That wasn't always the case. When was this change made?
That change was made, I want to say in the fall of 2025. I can get the exact date for you, but it was in the fall of 2025.
Okay. I'm glad that the change was made. Is sort of recruitment on all of the websites of all of the hospitals in the region, and Cedar Hill was the lowest. So that might have put into some of the things. I want to ask more about community engagement, because there's something I've learned about DC, and I don't know if it's DC specific, but I've been here for a while. Reputations there are people, like, even on the school side, you haven't been a student at that school for 35 years, but you still feel like it's bad, right? These are some of the conversations that we have. And so one of my worries is that in year one, Cedar Hill has gained this sort of reputation. And so now I have to sort of turn this around. Dr. Nesbitt, you mentioned that you all started the Cedar Hill Alliance for Health Equity. Is that work still continuing?
Yes.
Okay. How often is that group meeting? And is that a conduit for conversation around some of these things, or no?
It is, and Ms. where some of the UHS to Cedar Hill staff are engaged, and we've talked about opportunities for in that space. And it has waxed and waned, and I think a function of that has been the need for some of the Cedar Hill leadership and staff have been focused on clinical operations, but under her leadership, there is an increasing engagement of them in the work groups. And to answer your previous question about how frequently people are meeting.
Okay. So, I mean, Ms. Daniels, what benchmarks should this committee use to measure success?
Yeah. So I think that
by this time next year, I'm gonna give you a year. Because you've only been there for 8 weeks. And I think it's so a year from now, what does success look like?
Sure. So I think what success looks like, you will see a full complement of services, including all of your primary care, as well as the specialty services to amply take care of all of our patients in wards 7 and 8. I think that what you will see are, as a result of that, the metric you can use to measure ambulatory volume, as well as an increase in in our system-wide services when you consider the urgent care as well as the emergency department services. I think quality, from a quality perspective, on par, but likely exceeding our quality metrics from a national perspective. You will see an improvement in the health care of the residents of wards 7 and 8, and that will be measured by the social determinants of health. You'll be seeing an impact in that and a decrease in some of those issues around transportation, medication, healthcare.
Have you met with the team over at Whitman Walker?
I did meet with Whitman Walker on last week.
Okay.
Yes.
I don't, like Ms. Lockridge sort of said at the beginning, I don't think that the hospital is panacea. I don't think that a hospital can ever be panacea, right? I don't want actually people to have to come to your hospital, no offense, but like going to the urgent care down the road and seeing the doctors in terms of doing the preventative care over time. And so we have to think about this from a full system. I don't think that Cedar Hill can handle everything. You're not supposed to fix it all. In that regard, I want to ask Mr. Barrett, do we need a freestanding ED or would another urgent care work better? And I'm asking that because I feel like with a freestanding ED, you're training people to come to the emergency room in some ways when we want them to not come to the emergency room for things that are not urgent. That was one of while there's sort of a pause on that project, I'm curious, can we talk about whether or not that's really the need in the infrastructure?
Well, again, if we're talking the broader concept that we're talking about, and part of that, I believe the reason the district came on with UHS is they wanted an integrated system. So we talk a lot about system cohesion. And so the idea of decanting our ER for the tertiary, the acute, which is what we've done. We have 35 freestanding EDs throughout the country. It allows us to take on certainly at GW, the most acute, and then at Cedar, it will afford us the ability not to be in a position where we're dealing with those that are truly, those that fall into that category of treat and street, to use the local language.
Okay, I'm over my time. Councilmember Parker.
Thank you. Ms. Daniels, I wanted to come back to you. You mentioned that there was an immediate jeopardy citation that was found during a February 26th survey and that the citation was lifted the next day.
Correct.
How many surveys are outstanding to your knowledge outside of that one that was lifted?
Will you define outstanding? And the reason I asked that question is we had a recent survey in February. We've submitted our plan of correction. We consider a plan closed is once that plan of correction is accepted, and then we have a follow-up visit within the requisite time to ensure that what we said we would do in that plan of correction has actually been completed.
Does DC Health confirm that
Yes,
you have exited or that your plan meets our expectations?
That is correct.
Okay. I did want to follow up. There was a multiple on-site survey visit conducted last year in your time and leadership, but I do want to ask about the practices today connected to this. The visit was April 30th through May 5th with a follow-up visit on May 7th, 2025. And it found pretty damning things at the hospital. The hospital operated with one individual, I believe, waiting up to 51 hours for a bed in the hospital. It's when closed, which is one of the findings of the report or the survey.
Will you ask your question?
Let me ask it a different way.
Sure.
How does leadership today
So we have a surge plan that has certain triggers in it, allows us to know when we need to open up an additional, if we need to go on divert because we don't have either the space or the staff to take care of patients. And so we follow that capacity management plan.
Okay. And I'm assuming, let me ask, when was that plan implemented or created? Presumably it didn't exist May.
Started. So in February, I believe that the date of correction to that plan, or the date that it was last revised, would have been in the fall of the 2025.
Okay.
So yes, it would have been later than that initial visit.
What is the threshold for intervention for overcrowding or understaffing? Because that was also identified challenge.
So there are several factors. So one we look at what we call a NEDOC score, which basically measures the acuity level in the ED. We also look at how many beds. We also look at the staffing. Our staffing ratios on our med-surg units are 1 to 5. So, based on, typical acuity. And so we ensure that we have the ability to take care of those patients safely at that ratio. We have both the capacity and the nursing staff and the tech staff to take care of the patients.
Another finding was that there was a hypertensive emergency with the individual. This was on the news. I believe this person had to be medevaced away from the hospital. A typo, but with blood pressure over 200, over 171. I didn't even know one's blood pressure could get that high. And it was misclassified as non-urgent by the hospital staff. Again, now this predated you. Is learning from these instances, what protocols are in place to ensure that these types of misdiagnoses don't happen?
Right. So what I've done since my time at Cedar Hill is I take we have something called a STAR report where folks can freely, under psychological safety, freely report incidents that they believe are either near misses or situations that put us at risk. I have
files that report.
Any individual in the organization, any employee, from housekeeper on.
And who are they filing that to?
It goes directly into our system, and our risk manager, she reviews each of those incidents every single day.
Can those be filed anonymously, or do you have to identify yourself?
You have to identify yourself because it goes through a system, but there is no retaliation. Again, it's under psychologically safety and a system of just care. We don't. We encourage our team members to bring these forward because this is how we learn. And to that point, what I've done is I've taken each of those cases and used them as a case study. We have an established 8:30 a.m. safety huddle every single day, and we're reviewing those cases to be sure that everyone is aware of the issue, how we can avoid the issue in the future. And then in their huddle, when they go back to their teams, this is with the leaders, they go back to their teams in a huddle, and that information is cascaded.
Okay. If I can make a recommendation, I think there could be benefit to making that anonymous, because if I am worried about retaliation, maybe I do have valuable information you should know, but I'm not willing to risk my job to report it. Just throwing that out there. There were also findings that the physicians and nurses didn't record information accurately with this visit as well as others. What escalation protocols are in place now, as well as how are you vetting or that physicians are documenting in people's records?
So I have implemented an audit process on all of the records. We do something called an IPASS round every single day. And so the nurses, the bedside nurse is responsible for performing that round. As part of that round, they have to do what we call a bedside shift report, where they're actually handing off to the oncoming nurse as they are the offgoing nurse in front of the patient and sharing that information. The leader of that unit, the unit-based leader, is responsible, and this has to be documented in our EMR system. The leader of the unit is responsible for pulling that information on a daily basis, reviewing to ensure that those records have been closed, that they've been completed and documented, and then we report out in our safety huddle every morning at 8:30 what the compliance has been by unit.
Okay, and now, again, I'm not trying to shame and blame the hospital, but I do want to get to the bottom of some of these. There is also a report of a wrong site surgery. Maybe there were multiples, but one that I identified, an individual came in to have an appendix removed, and instead their ovary was removed. They only found out that their appendix wasn't removed weeks, months later, when they actually had to have their appendix removed at another institution. Given the partnership with GW, it's my understanding that, at least in the past, you would send specimens to GW for testing or follow-up. How does that happen? That I'm supposed to remove an appendix, I remove an ovary, I'm sending information to GW, and nowhere in that process does someone say, hey, there's an issue.
So what I will say is that unfortunately mistakes do happen. I would say that every case at that level, so every case is given a level, a harm level, if you will, and then cases that are at the most severe harm level, it goes into an immediate, what we call root cause analysis.
So I just see my clock. I'm sorry to jump in. So can you just speak to the process where specimens are going to GW? Is that still the case?
That is still the case.
So what is that process? How do we ensure that there's a stopgap so that if there is something wrong, someone at GW is saying, hey, we have an issue here? Because there was another hospital that ultimately identified that this individual's appendix was still intact.
The expectation is that the pathologist who is reading that is documenting that information and then is providing that follow-up information to the surgeon.
So what's the protocol today to ensure that we don't have another situation like this?
It's 100% auditing to ensure that we don't have surgeries. So every morning I receive a report for any cases that occurred throughout the last 24-hour period. And then we are actually going through and reviewing those through my chief quality officer is going through and reviewing each of those cases on a daily basis.
Okay. Last question. I know I'm at time, but how do you ensure that staff actually do feel safe to report unsafe conditions, that errors were made without fear of retaliation?
Sure. So we've started a Stop the Line campaign, and the Stop the Line campaign is a campaign that allows the physicians to work alongside the staff to let them know that there's equity in the process, so that if I, as a team member, see that a physician should not continue with a particular case for whatever reason, that they are empowered to stop the line without any retribution or any retaliation. This is collaborative work.
I'm sorry, I'm not a doctor. When you say stop the line, does that mean someone has the power to tell the doctor?
Exactly. So a nurse, a tech need to stop this case, or we don't need to move forward with this case because of whatever they're seeing. And then we will immediately stop the case and do a review of whatever the particular issue is that is being addressed.
Okay. I have so many follow-up questions. But just who's the arbiter in that? Like, we have a sick patient in front of us. Someone stopped the line. Who gets to say the doctor is right or the tech is right?
Right. So the escalation process would, first of all, would be the attending who's in the room. If it needs to be escalated beyond that, it would then go to the chief medical officer. If it needs to be escalated beyond that, it would then come to me.
Understood. Thank you. I'm over time, but thank you.
Of course.
Councilmember White.
Yes, thank you. I asked a few questions about how many vacancies you have in staff. Someone was supposed to get back to me on that. If we can start.
90. Yes.
Okay. And could you speak to what those types of positions are?
Those would be any non-nursing positions. So those would be tech positions. I believe that we have maybe 3 or 4 cook positions in that. In that we have some ancillary positions like radiology techs in that number. We have pharmacy techs in that number as well. So it would be non-nursing staff, and it could include clinical team members in imaging as well as support staff persons in food and nutrition services.
So this is 90 plus the 60 plus nurses.
That is correct.
All right, got you. In your testimony, you gave some record about getting seen in an emergency room may take 48 minutes for initial person to be seen. And I don't know if that speaks to, I know it doesn't speak to an entirety time, because I think that in your report that I read, it said about 5.5 hours. Can you speak to the specifics of what that is you were explaining about the 48 minutes?
Sure. So that's the time that the patient arrives and checks in to the time that they are actually seeing a physician in the triage or a provider in the triage to assess their situation.
And on average, how does Cedar Hill measure up with other local hospitals?
We're at about 48 minutes, and the average is 46 minutes.
Yeah, I'm talking about time in emergency room.
Total time in emergency room?
Yeah, it's what, and what, how does it relate to other hospitals?
That information I don't have with me, but I'm happy to follow up.
So you all produce a report. It said something about 5.5 hours. It was there in the presentation when I was there.
I'm not sure.
Are you referring to the board meeting?
Yes.
I'll have to go back and pull the minutes for you, and I'm happy to.
Is anyone there has that information? That's a pretty baseline information about how long an average person stays in an emergency room.
So if I may, I mean, that you can go to the CMS website, Hospital Compare, but the reality is it does it by level of intensity. So low volume, medium volume, high volume EVARs all have different door to provider, total turnaround time. But by rule of thumb, where we are, we're probably 5 hours shooting for anywhere between 180 minutes.
Yeah, this is a hearing, so I'm asking for public record. On average, how long is a person there in the emergency room?
We'll follow up. Thank you.
Somebody should be able to get that information. Everything is a follow up. I come back to that. Let me see. Ms. Daniels, you talked about a plan to turn economically to get out of the red per se. Can you walk us through what those goals are specifically, the metrics, and how we know that we're moving in the right direction, and how long you think it's going to take to get it turned around? Is it 1 year, 2 years, 5 years? If you can give us some more specifics to that, that'd be helpful.
So I think you'll see improvements within this year. So by the end of our fiscal year, which is December of this year, when you think about the balance sheet and kind of what that net profit is at the end of the day, on the revenue side, the top side, it's the access. It's a growth strategy to ensure that we're bringing in elective cases, that we're growing our ambulatory services, and that we're managing very well our inpatient throughput. On the expense side, it is looking at our productivity and making sure that we have the right number of staff doing the right work at the right time so that we can take care of patients. It's also looking at our supply expenses and making sure that they're commensurate with the volume that we have coming in and that we're managing our expenses well. Also, things like our length of stay, making sure that we're getting patients in and out of the hospital according to their geometric length of stay, which is the time that's estimated based on their condition and the acuity level of their care. So I think that it is a comprehensive kind of strategy to look at profitability and to ensure that we are financially sustainable as we move forward. The greatest opportunity that we have, though, is the growth strategy and ensuring that we're improving the volumes throughout the facility.
Yes, and also marketing and keeping the name good, because that also affects the care of people wanting to come there. And I guess I was looking for, if we do these 4 things, we should see some 25% improvement here, 15% improvement there, anything like that to help us as a council, because we have to be as responsible to the public for putting almost $400 million into the hospital. What's our return on investment of providing a quality healthcare system East Anacostia River? Do you have any of those type of examples?
Yeah. So how am I going to go out and increase the volumes in the facility? How am I going to increase those elective cases? That is my direct interaction with physicians, and that be community physicians, and making sure that they are, to your earlier point, that they are credentialed, that they have the supplies and the staff that they need to feel comfortable in providing services in the facility. That is my work to do in terms of making sure that we're getting their credentialing applications in and making sure that there are no bottlenecks when it comes to onboarding them and providing them with privileges. So that's one tactical action that will be taken to grow the volumes, is bringing those community physicians in and removing any kind of barriers that they may currently be experiencing.
Now, I spoke briefly about marketing. As you know, the fastest way something travels is by word of mouth, and now through social media. Cedar Hill has not, in this community, has not gotten a good reputation, as the course of this year. What type of marketing tools, outreach and engagement do you all have planned to re-engage, make people feel safe, make sure you can come there and have great experience and high quality services? What are some of your thoughts around that?
Yeah, so I'm really excited to answer this question because we have a full, comprehensive and thoughtful public relations media campaign that will actually be rolling out this month. That campaign has several layers to it. One is some very grassroots efforts where we're actually going beyond the walls of the hospital out into the community. We're doing pop-up clinics at some of the local churches in the community. We're doing some pop-up clinics in some of the other community-based facilities. We're partnering with the federally qualified health centers to do some screenings and some education. Also kind of building out some networks as we look at the whole continuum of care. Madam Chair Henderson mentioned earlier that we can't do this in isolation. So a large part of what we're doing is reaching out to our partners in the community to build networks. For example, we've already signed on with Mama Toto and the doula-driven program for maternal child health. We have a lot of work that's going on in April for Black Maternal Health Month. We're working, the Nestle Corporation has tagged us as one of the beneficiaries for some donations that they will be making around maternal child health. And so all of that is packaged and will now be promoted. In addition to some media packaging, commercials, things that will be going out on social media. We also have some collateral material that we'll be sending to residents in the community, now letting them know what services we're offering in our ambulatory space and how they can access those services. So a full comprehensive plan that's from grassroots efforts all the way up to kind of marketing and media publication.
Thank you. I have less than a minute. I want to jump to you, Dr. Nesbitt, real quick. Welcome. As I understand it, your work related to here involves research, academics, and workforce focused on health disparities.
I'm sorry.
Can you hear me?
Yeah, Dr. Nesbitt had to leave.
Oh,
so,
okay.
Yeah. If you have another question that you wanted to use.
I did want to ask about she spoke to the immediate jeopardy citation in his testimony. His answer on what the plan is for a full-time CEO. I think it was asked several times. If anybody have any clarity on that, I know you got a lot of praises, Ms. Daniels, as the interim. We want to know what's the process for full-time.
So I'm sorry, I'm trying to balance all this right. So 6 months is the horizon we're looking at in backfilling that position. And Councilmember White, if I may, just to follow up on your question, in terms of total turnaround time in the ER averages, this comes directly from CMS. This is October 24. The median average in the country, 2 minutes. DC is the longest in the country at 5 hours and 14 minutes. So that's turnaround times. As it relates to key metrics in the industry, we look at median arrival to doctor exam in April 2025, which is an important date. We were at 87.9 minutes. In March of 2026, we're at 46 minutes. So that's a 47% reduction. Median arrival to triage, we were at 26 minutes. We're now at 11 minutes. That's a 57% reduction. Left without being seen rate, which is a marker in the industry, was at 6.19%. It's down to 3.29%, a 47% reduction. So I would assert that there has been considerable progress made.
Thank you for the clarity with that, and with those numbers are extremely helpful for us to monitor the progress of this hospital.
Thank you, Councilmember
Also,
White.
hey, I see Dr. Bennett as well. Hello, I see you in the background. I'll say hello there.
She'll be up next. I just want to have I have a couple of just tie-up questions, and then we're done with this panel, and we'll take a 5-minute break because I think Deputy Mayor Turner has slides that we need to load. Ms. Daniels, you talked about, I think, the STAR process. No. Well, yes, STAR to report and then stop the line in terms of the campaign. Mr. Elliott, if your physicians, because I think this part is getting confusing to some people for the public, right? GWMFA provides physicians. And as you guys explained to me, you come in, your physicians come with themselves, their jackets, and maybe their bag, but everything else, Band-Aids, gauze, scheduling, nurses, techs, et cetera, that's all UHS Cedar Hill's responsibility in terms of providing. If there's a situation where there's a physician MFA who observes something that they feel like is problematic within the Cedar Hill operations or the hospital, what's their reporting structure? Or is there a reporting structure where they can report their concerns?
Thank you for that question. And I do, before we do that, I do want to pile on and say it has been a welcome addition to have Ms. Daniels and her expertise to help put in these types of processes. So our physicians would join this process, just like Ms. Daniels explained before, and raise their hand. If they're not getting traction there, they would raise it up to the medical director and even up to Ms. Daniels or to their chair at the clinical department at GW and or myself. So there's plenty of mechanisms to stop the line or provide STAR feedback. So they're integrated and woven into the healthcare and safety. So I don't want to give the impression that we punch a clock and we are embedded into the healthcare safety and quality measures there and a big part of that. And if there are certain things that we feel are unsafe, we would have a conversation with our UHS colleagues and either delay those types of services until it could be safe or continue forward when it's safe. So there's plenty of mechanisms to raise the hand there.
Okay. Also, Ms. Daniels, in a response to a question with Councilmember Parker about a particular incident and I think the appendix mistake, you talked about how you review it as a case study. There was a case that happened in February where a patient was, or a surgeon had labeled something as a hot urgent, which has a particular connotation for the industry. And unfortunately, that wasn't adhered to. What happens in those particular cases? Because to me, that feels like that's not just a case study, that's a process. There was a process breakage in that.
Yes. So in the very same way, that particular case, I think, was around the surgical services.
Right.
What should have occurred in that case is that that was brought to our attention, I want to say, from a team member. I want to say a nurse brought that to our attention. And so that was also escalated through the process. A physician, one of the physicians was also involved in that, and that escalation needed to go to the medical director of the surgical services and was then subsequently escalated to our chief medical officer, who then called for an RCA to review that entire event to understand what some of the breakdowns were and some of the opportunities for improvement.
Okay. Well, I want to thank you all for your time. I know I've kept you longer than I said that I would. We're going to take a 5-minute break so we can set up. We may have some follow-ups potentially. We're gonna have a conversation with our government witnesses because, like I said, the whole point of the relationship in terms of building Cedar Hill and bringing UHS in was to get out of the district government doing the day-to-day operations of a hospital. And so I myself am trying to understand with my colleagues, what does our oversight look like? Because it can't look like what it looks like for everyone else. I want to treat y'all like Sibley and all the other members of the DC Hospital Association, except for St. Elizabeth's, because we have a more direct relationship with them. So we're trying to figure out what does that look like in terms of monitoring essentially our contract. And so I'll have that conversation with our government partners on that front. But I want to thank you for being here. I want to thank you for your time again, for the meetings and conversations we've had. And of course, the prior pieces. Ms. Daniels, you guys have a full-time HR now?
Correct. Yes,
Okay.
we do.
Because 90 staff positions, that's the nurses are wonderful, physicians are wonderful, but you can't have any of that operate if you don't have a tech.
Right.
Or if you don't have housekeeping or someone in nutrition services. So those positions are important too. Okay. We're going to take a 5-minute break. Thank you so much.
Thank you.
Okay, and we're back. We have our government witnesses with us, Dr. Ayanna Bennett, who is the director of DC Department of Health, and then Wayne Turnage, who is the deputy mayor for Health and Human Services, as well as the director of the Department of Healthcare Finance. I do need to swear you all in, so if you can raise your right hand. Well, you and any person on your team who might speak. I see you, Renee. Just hanging over there. All right. Do you swear and affirm under penalty of law that the testimony you're about to provide to the Council of the District of Columbia and this committee is the truth, the whole truth, and nothing but the truth? Great. Oh, Director Turnage, are you going first or? Okay. Wait, are you providing testimony? Oh, you are just answering questions. Okay. Your mic's not on. It's good to see you.
It's good to be here. I am here on your assurance that neither you or Councilmember Parker will send me into cardiac arrest, but I brought Dr. Bennett just in case you do.
She said pediatrician.
Good morning, Chairperson Henderson and members of the Committee on Health. My name is Wayne Turnage, and I serve as the Deputy Mayor of Health and Human Services and the Director of the Department of Healthcare Finance. I am here to testify regarding DHCF's and the government's oversight responsibilities addressing the district's agreement with the Universal Health Services. I'm joined at the hearing by Melanie Williamson, who you know and who recently assumed the role of Chief Operating Officer at DHCF, now serving a joint role as my Chief of Staff. And I'm also joined by key staff and the amazing director, Ayanna Bennett, Terry Thompson, who runs SHPTA, and Renata Cooper, who carries significant regulatory responsibilities for hospitals, including Cedar Hill. With Ben Stutch's departure, Melanie now provides the critical nexus between DHCF, UHS, Cedar Hill officials, and the district's regulatory agencies responsible for oversight of the hospital's operations in the city. Let me say at the outset, allow me to disabuse people of the notion that Cedar Hill is an unregulated listing ship. It's not. There is much work to be done. I would attest to that. But I believe Cedar Hill is well on its way to becoming the community hospital that is contemplated by the agreement for this city. Not without some prodding where necessary, but I believe it is well on its way. Also, Madam Chair, with respect to your request that this be a forward-looking roundtable, I ask for the personal privilege to look back just for a moment at the selection process that led to the agreement with UHS. The community narrative around this issue has been irresponsibly poisoned by a self-serving false narrative. So before these flagrant prevarications ossify and metastasize in the community, I think a quick fact-based presentation is warranted on how we got to where we are with UHS as the operator for Cedar Hill. If you see on slide 5, we had essentially a process that stretched across 5 years trying to find an operator in part for us for Cedar Hill. It began with a partnership search. This is slide 4, I'm sorry. Began with a partnership search for United Medical Center. So in that effort, we secured 3 healthcare operators who agreed to explore a partnership with UMC. And these were healthcare operators of significant note. That happened in the winter of 2015 to the spring of 2016. They all expressed interest, but they all eventually walked away from the project. No doubt, fearing the massive subsidies that the district had been putting into Cedar Hill. Probably, if you look at the beginning of UMC to its end, probably over close to $500 million subsidies to keep the hospital upright. A lot of it done under the guidance of then committee chair David Catania, who was very interested in making sure people in Ward 8 had health care. So when they backed away, we went to a consulting firm, Huron, and asked them to do a detailed market analysis and help develop some criteria for the new hospital, for a new hospital, because it was clear that UMC would not find an operator that would be a full risk operator for that entity. Huron did its work from early 2017 to spring of 2018, and they delivered four major deliverables, which I outlined in the slide. I give special note to the fourth deliverable, which was we asked them to tell them, we gave them what our image was for an operator of a new hospital, and we asked them to help us come up with partnership criteria. So once we had that report, we directed Huron to engage as many potential hospital operators as possible, not only in the DMV, but across the country, to see if they would be interested in operating a hospital if the district essentially handed them the building and said, you take full risk for the operations. Huron interviewed about 16 regional and national healthcare hospital systems, and we received confidential expressions of interest from a limited number of major healthcare providers in the DMV market. One expression was informal. But at the end of the day, we had only three providers, potential providers, who would agree to even compete for the opportunity to run a new hospital. I mean, a brand new hospital at full risk. So the reason I walk through that is to give the community some sense for what the effort that was made to try to find an operator, and two, the difficulty that we experience in finding an operator under the most where the district is paying for the capital cost of a brand new hospital, roughly $440 million. And we would be asking the operator to take on the business of running a hospital, something that they are known for, at full risk, with a $25 million stop loss provision that covers some losses up to X number of years of the contract. So that out the way, I also want to go, if you go to slide 6, I want to make sure people understand the nature of the agreement that we have. Our agreement is with Universal Health Services. It is the agreement that I'm sure you have read multiple times, Council Member, that basically outlines the process through which Universal Health Services will direct the work at Cedar Hill. Our contract is not with GWMFA nor George Washington University, and as you know, they have been in significant negotiations for a revision to their agreement, and I understand this morning that there's a press release announcing major progress in that regard as well, and that will be very beneficial should the major progress turn into a final agreement. So Universal Health Services fully owns George Washington Hospital, and Cedar Hill Operations operates as a part of that system. It is intended to be a community hospital embedded in an integrated system of care where there can be a seamless movement of patients depending on their need, from community care to trauma care if necessary, and to certainly more complex care at GW Hospital. Now, I'm not going to belabor you all with the nature of the 4 agreements on page 7, other than to say that there are 4 agreements: a collaboration, operating, development, and lease agreement that govern this really, I think, wonderful project. The most pivotal is the operations agreement, which sort of guides the work of the executive in its relationship with Universal Health Services. If you go to slide number 8, excuse me, my mouth is getting a little dry, so I have to. This is a critical slide. Slide number 8, excuse me, my mouth is getting a little dry, so I have to. This is a critical slide because it speaks to the significant regulatory authority that the government has over Cedar Hill, but not because it's Cedar Hill, but because it's a hospital. As the director of Newsroom, and we also get an investment report. They agreed to spend $75 million in addition to the cost of operating the hospital. And so we get a report on how they are doing on Cedar Hill. Again, because it's a hospital and not just because it's Cedar Hill. DC Health does go in and whether and how they are addressing uncompensated care. There was some mention in the community about whether or not, are we at a point where you want to pursue with the Attorney General a possible breach of contract? That is just unmitigated nonsense. UHS has not reached a point where they're saying they cannot do portions of the agreement that was signed last year, that where there's work to be done, they are fully acknowledging that some of the work has lagged, but they have also given us a schedule of when they plan to complete that work. DHCF, the agency that I am director of, is responsible for rate setting, and I think we have one of the best set of analysts, actuaries, and rate analysts in the city. And we do an outstanding job of setting rates for hospitals, not always to their liking, but certainly we are very thorough and analytical. DSLBD, as you know, is responsible for their CBE compliance, and DOES monitors their first source compliance, the workforce partnership, and their training arrangements. DSLBD, as you know, is responsible for their CBE compliance, and DOES monitors their first source compliance, the workforce partnership, and their training arrangements. In this process, there are some key operational questions that we ask internally, and I will call the health department occasionally, and I'll ask for information. But there is a cadence that we've established where at the annual date of the hospital's opening, we will start collecting formally and data on. We collect the data now, but we'll start presenting it formally as the hospital's performance with respect to these key questions. We asked about the number of complaints regarding patient quality and safety at Cedar Hill, and we asked whether those complaints were satisfactorily resolved. Of course, we never tell DC Health how they should evaluate a complaint or whether they should evaluate a complaint. That would be an egregious breach of duty on my part. So we don't do that. We ask them, tell us about the complaints and tell us how they were resolved. We asked whether or not Cedar Hill has fully met the requirements for having the number of licensed beds on site, inpatient service lines and outpatient service lines. And if not, is there a reasonable plan in place to meet these requirements? If SHPTA tells me that Cedar Hill is not meeting its licensed bed requirements, they don't have those beds in the facility and plan to bring those beds in the facility, unless they can get some agreement from their mayor to accept that, then yeah, you would be talking about something approaching a breach of contract. We asked more recently, and we'll ask consistently, how many times and why has Cedar Hill been forced to execute a full hospital diversion? Are there plans in place to mitigate the number of such occurrences? And I will say, for the sake of full transparency, when I looked at the diversion numbers, we asked whether or not Cedar Hill has met its CBE requirements, and what are the numbers that demonstrate compliance or failure. And then we asked how much of the $75 million target for this project has been achieved by UHS. Now, I was planning to conclude my presentation at this point, but I wanted to do something. Director Daniels was very modest in her presentation, and I wanted to go to some slides that using some data that I drew from across the city and from some of her testimony, but I wanted to highlight it so people will see what is going on at Cedar Hill with respect to some quantitative measures. Clearly, as we stated, and it's shown on slide 12, Cedar Hill has met its inpatient licensed bed requirements, but like other hospitals, it is not presently staffing 100% of those beds. They are staffing 59% of those beds, which is not the lowest in the city. Howard University is at 37%. But, and I think you will see some improvement on this measure as the hospital continues its operation. And again, because we are regulators and not operators, I don't engage with the hospital over its staff beds. I mean, that's a hospital operator qualified to direct anybody on. I know that I have the legal authority to do it, but my sense is from talking to UHS and Kimberly Daniels, which I do regularly, that that number will improve. May not get to 100% like you see at Children's or St. Elizabeth's. George Washington's at 95%, Georgetown is at 92%, and Washington Hospital Center is at 90%. Now, that is, monitored by Terry Thompson. I counted 14. I asked Terry to send me some data on what service lines they were operating and what service lines were in development and whether or not they had identified any that they were not going to do. And, I'm apologizing up front if I've counted in error, but I haven't been feeling well lately. But by my best count, they have to meet 14 outpatient service lines. They've met 7. Those 7 are listed to the left of the page, and they are in process of meeting the remaining 7, which is outpatient dialysis, a urology clinic, a cardiology clinic, primary and OB clinic, another OB clinic, which I'm not sure, that may be a typo, orthopedics and neurology. Now, all of these clinics, service lines have dates that such by July 1, I believe, of this year, they will all be online. That is their promise. Now, if that doesn't happen, that is where we as a regulator would communicate with UHS that, these were not implemented when the hospital was open, and we understand the reasons. These are the dates you've given us that they will be fully online, and we expect that. And so if they don't meet that, then we'll have significant conversations about, what the problem would be and whether or not they're going to be able to fulfill that requirement. Now, something that I think is overlooked, if you go to the next slide, in the first 11 months of operation, Cedar Hill has experienced 3,243 total visits. That's a 30% higher than United Medical Center reported in its last 11 months of operations. I have one criticism of Cedar Hill in its execution. It would be at the very beginning of the process. And I remember having this conversation with Kim's predecessor, Kimberly, Kim Russo, who I think is just a superstar. And one thing she told me that we didn't agree on, but I couldn't argue with it because she knows this stuff a lot better than I do. In their pro forma for the new hospital, they based it on the MC. And I don't know if it was the last 11 months, but it was somewhere in that time period. I thought that was a too conservative of a estimate of the business that they would see in their first year of operation, primarily because Cedar Hill is a new hospital, and it would attract a lot of folks some of them would be interested in seeing how it worked. So I thought they should have planned for a slightly higher census. But be it as it may, they are operation. There are only 3 hospitals in the city. Say that real slowly. There are only Washington Hospital Center and Children's that have experienced a higher number of emergency room visits compared to Cedar Hill in its first 8 months of operation. And I would remind people that George Washington University is a level 1 trauma center, MedStar Washington Hospital Center is the largest hospital center, second largest in the region, is the largest in the city. And of course, Children's is our national jewel for serving kids. These hospitals, and some of them barely have, in the case of GW, they are seeing patients and they are doing quality patient work. Have they made mistakes? Yes, all hospitals make mistakes. If you look at medical errors across the country, the numbers are in the hundreds of thousands. They are all unfortunate when they happen, but they do happen. And the question is, can you avoid them in the future? Next slide. I asked the Department of Health to tell me the number of complaints that have been reported on Cedar Hill based on patient visits and whether or not those complaints were successfully resolved. As you can see, since its opening, Cedar Hill has been hit with 38 complaints, which is less than 1% of patient visits, and 76% of those complaints have been resolved. If you look at those complaints as a proportion of not just total visits, but total ED visits, I think the number of the percentage is like 0.008 of total visits. Again, complaints are to be taken seriously as these are, and when they create unfortunate outcomes, they must be addressed, and they must be addressed expeditiously. But the notion that the hospital is overrun by complaints due to poor care is not supported by the data. Now, this is the area where I think Cedar Hill has to do some work. One of, a couple of areas. They've been on full hospital diversion or partial hospital diversion 20 times during its first year of operation. I don't know if Dr. Nesbitt remembers the numbers for the other hospitals, but they don't particularly come close to that. Bennett, I'm sorry, I called you Nesbitt.
Yeah, you did. But that's
You didn't smack me? I'm sorry, Dr.
about Dr.
She was sitting there, and somebody, my blood's still not flowing that well, so I still have this delayed reaction. 19 full hospital diversions, I think, is high, too high. And the reasons are listed to the right. Typically, they occur because of facility crowding. They also occur six of them were other reasons, and I would think Renata may have to comment. I don't know the details behind those other reasons. If she has them and you want interested, she can provide it. A quick story. I remember, actually, I was visiting with Kim Russo once when she was at GW, and a staff member came in to said that they wanted to go on full diversion, and she had a fit. She wouldn't allow it. So it's not something that hospitals take any pride in, and they want to avoid it. And I think this is something Cedar Hill will work on, and I think they will do a good job. With respect to Universal Health's commitment to the city, they agreed to spend $75 million in addition to the cost of operating the hospital. They are well on their way to achieving that. They've reached 77% of that investment goal. Today, they have invested or will invest $3 million to open the Ward 8 urgent care, which is doing brisk business. I would shudder to think what the emergency room at Cedar Hill would look like if UHS did not have the wisdom of opening that urgent care facility right around the corner. They spent $17.1 million to build an additional floor at Cedar Hill so that if we get to a point where volume is continually overrunning a fully staffed hospital with respect to its licensed beds, they can add beds without major disruption to the hospital. They're spending $28.7 million to build the Ward 7 FED that we talked about earlier. And they're spending $9 million for in-kind services in the they spent $9 million on the construction management of Cedar Hill. So to date, they have invested $57.8 million. The next slide deals with their performance with respect to First Source. It has been strong. They have made 175 new hires, and that rate of those new hires, 132 were DC residents, which is well above the 51% rate required by law, and they are in what takes so long at the new site for the freestanding emergency room. It's a very complex site to negotiate. It was sitting up on a hill, it was an old school, and I think they underestimated, not just Cedar Hill, but the government underestimated how difficult it would be to get that site ready. But that site work will be finished and turned over to UHS by the end of 2026, possibly sooner. So we expect the construction to end in late 2026, early 2027, and the council should receive the land disposition documents prior to that time. And if you all act expeditiously, hopefully we'll have after a 15-month construction and a 2 to 3 month inspection process, the facility will be open no later than the spring of 2028. So those are my comments for the record, Madam Chair. And again, I would close by reemphasizing that I do not share the view that Cedar Hill is a listing ship. I think it has had some bumps in the road, as you would expect in any new operation of a very, very complex entity such as a hospital. But I think they're well on their way with the great leadership of Kimberly Daniels, well on their way to becoming a hospital that we want it to be. Thank you.
Thank you. We'll do 10-minute rounds, and then we'll start from there. Turnage, and I also want to sort of note, thank you, Dr. Bennett, for being here. In this role, you're the regulator, you're the state regulator, and you've been doing your job. We have the reports to note that the staff has been working, but we have some follow-up questions. So I'll start with Director Turnage. Who is the current contract administrator within the district?
Providing oversight to the contract. If there are changes that require the mayor's approval, she will bring that to my attention.
Okay.
And I will bring it to the attention of the city administrator and the mayor.
Have there been any material changes to the agreement since the hospital opened?
No.
Okay, so let me start with some other questions before I get there. Who made the decision regarding Cedar Hill's opening date?
Oh, that decision was made based on, I was a part of that process, so I'm trying to sort of call upon my memory to figure out exactly how it worked. We worked backwards from what we expected to be the completion of the construction process. Mm-hmm. And the concern was, once you complete construction, we'll sit there vacant for months.
Sure, but if you don't have staff.
But we were talking a year before the hospital was completed, and we made sure that everybody, that UHS understood, and UHS agreed with it, as I recall, that we would be opening a year from the date that we had that discussion, and we would target the date as being the opening date of the hospital or the completion of the construction date. Actually, could have been contemplated and accounted for.
Did at any point UHS say we're not ready? Did they have the space to say that?
Sure they did. If UHS had come to me, because you got to understand, I report to the mayor and the city administrator.
Right.
And I was informing the mayor that this would be a go in April of 2025. If UHS they can't be ready, and we agree with them.
No, not GWMFA.
No, whatever reason they would have offered.
Okay.
If they had come to me and said, we will not be ready, I would have said, to the CA and the mayor, we're not ready. But I had multiple conversations with a lot of people in this process, and there was the only entity, the only person who said that, well, we might not have the staff was Dr. Nesbitt. And this is a year out. And as we got closer, when those conversations, as you would imagine, they would, my question was, we're still 6-7 months out. Why won't we be ready? At no point did UHS say, put the brakes on, we won't be ready. They said,
so you were not aware that in December of 2024, Cedar Hill still didn't have a HR.
No, but I wasn't involved in that part of the process. I was involved with making sure that my attestations to the city administrator and the mayor that they would be ready to open in April, they would be ready. And you gotta consider this. I was focused on, when I talked about staff, I was focused on the fact GW. So what is the complication from going to UMC to GW?
I don't necessarily want to sort of go back and forth. The reason I'm asking that is I want to make sure that the decision to open that hospital was not a political one. It was not about the ribbon cutting that was driving it, but rather was the hospital ready for operations? And that people have the space to say, hey, you know what, we might need another month, or did they feel like they couldn't?
It was me that went to the South, the opening date, until we said we were certain that it was to be in April.
Okay. You said in your testimony, well, actually just in the question that I asked you, that there were no material changes to the hospital. Board.
From day one.
Which day?
The day the board was constituted. If and I know from my past experiences the difference between a governing board and, for a hospital and an advisory board. This board is not a governing board for a hospital. I think the language in the operation agreements is probably, unfortunately, mischaracterized.
Wait, who wrote the agreement? Which offices were involved in that?
City administrator's office, all of the resources that he would have, and I was in the room. But when I saw governing board, I didn't think that we were talking about a typical hospital governing board. The reason,
okay,
if you look at any hospital governing board, I was at one meeting several weeks ago at Children's. At Cedar Hill, 11 of, I believe, the majority of the members are from UHS. You can't have a hospital governing board with the entity that's being governed having the majority of the members. That's an advisory board.
Okay. Has the mayor appointed all of her individuals to the positions that she has for that board?
She appointed me, and I understand there are 2 that are presently being vetted.
Do you know the timeline for those individuals?
I do not, but I will check with...
hopefully before the retreat for this board.
Yeah, that would be helpful.
Might be.
Yeah.
Nice little onboarding.
Yeah. Retreats are overrated, but I think this is a good one.
Wow. Retreats can be a helpful tool for everybody understanding their rights and responsibilities.
They can also be boondoggles, but we won't go down there.
Ms. Williamson, I know you're new in terms of this role now, and I hope Wayne has given you a raise, but here we are. Do you receive the reports from DC Health when they do surveys and document issues that arise from Cedar Hill?
So I can't speak to what my predecessor may have received, but that cadence is not currently established with me. Right now I'm working on understanding the full structure of the agreement, ensuring that I have engagement with UHS as well as with the government partners to fulfill the review of our annual report, which is due in April.
Okay.
But obviously, you know,
there's a purpose behind it. There's essentially like a 2-year runway before the district government can sort of have conversations around sanctions or whatnot in terms of challenges with regard to quality. Why was the 2-year ramp up?
Because you want to give a hospital time to stabilize its operations.
Okay, so at what point, and you've mentioned this, what point do typical startup issues become contractual performance failures?
I think when there is a systematic and long-standing failure that creates certainly patient safety issues, I think that is a level of problem that would require us to basically the operator could continue to do the job. We've not seen that. You also have to remember CMS has a fairly rigorous reporting process, and DC Health can comment on that, but they look at significant quality data for all hospitals. If they see evidence of problems,
we have a different financial relationship in terms of Cedar Hill. So are you receiving the reports?
I can get any report that I ask for, and they've been, DC Health has always
You've asked for them.
Sure, I called Dr. I call Dr. Bennett all the time, sometimes weekends and nights. When I hear things that triggers a request for a report, I talk to her staff. I talk to Terry Thompson regularly. Renata and I communicate by emails, and Renata communicates with Melanie. So, but we just established a report cadence around the annual report to the mayor. So what the thinking is, when we go to the mayor when UHS comes to the mayor with the annual report, we will have reports from all of the government entities that provides their UHS is doing that will supplement the reports and also serve as a check on the information that UHS is providing to the mayor. Again, you're
putting a lot of stock on an annual report.
Well, it's the data that. Have you seen the format for that annual report? It's pretty extensive.
Sure, but also, Dr. Bennett, how many complaint-based surveys has DC Health conducted of Cedar Hill thus far?
So I just want to clarify that the complaints are not necessarily number of incidents. So some of them are of the same incident. And so we've done 8 surveys related to those, but some of those surveys bring together multiple complaints. The current one is 9. So those are related to not necessarily 9 different incidents, but 9 different complaints.
8 surveys in 11 months.
Yes.
Is that common?
No.
Okay. Councilmember Parker.
Thank you. Before I zoom into my questions, when is a fair point for us to say, all right, we should expect the hospital to be flying high?
If you look at the data on new hospitals, you would expect to be able to say that they are stable. They've stabilized from an operational standpoint. Throughput, sort of mastering what their workload is and using staff to match it, stabilizing their performance. People don't talk about the fact that some of the challenges that Cedar Hill has experienced. It's not because of a lack of spending. Cedar Hill their financials do not look good, and if this was a city-owned hospital, you all would be looking for maybe $50 million to find in the current budget to pay for the operation of the hospital. So take a minute. And my hope is that the finances turn around when the operation stabilize and this negative narrative in the community is properly rebutted and people understand that they can go to the hospital. All hospitals have risks. You know, I just came out of the 2 hospitals, actually had 3 in the last month. And I can't tell you how many times I heard cold, cold, cold. People were dying. So it happens.
Slow to act with urgency with Cedar Hill, given the population it serves?
When you said district partners, who are you talking about?
UHS, GW.
Nonsense. I mean, based on my conversations with, Kimberly, based on my conversations with Jason, the notion that they are less concerned about the challenges at because their population is predominantly Black.
Well, we can't judge their concern.
Right.
We can reflect on the actions that are being taken to stabilize the hospital, which informs my original question. At what point do we say the sub-performance of Cedar Hill is no longer acceptable, because by this point we expect you to have stabilized as an institution?
I think you give them the time that they have asked for with respect to, first of all, I think the measuring point as to where they are. So that would be this month. I think we're in April. And then they have said that they will have outpatient.
Jumping in just because of the clock. Mr. Baird earlier said, and within 6 months, they expect to have a CEO in place. Is it fair to say within that 6-month window, leadership as well as operations in the hospital should be stabilized?
Well, I think certainly. I think within 6 months, it should certainly be stabilized. And my hope is that they have the good sense of keeping Kimberly on. I think she's phenomenal. She has great operational skills. You wouldn't be
putting your finger on the scale, would you?
No, I mean, I look for good people. Understood. I mean, it would be to my detriment to have.
So just zooming out,
okay,
and I'm getting feedback, but zooming out, it's been a rocky takeoff. But within the next, and there's been progress. I do want to acknowledge there's been tremendous progress made in recent months and time, in part due to the work of Ms. Daniels. But within the next 6